long-term comprehensive treatment, drug treatment of the patients in post-op period. And today we have an international team. I would like to welcome international panel of lecturers. I would like to welcome everyone, esteemed colleagues. We have Dr. Professor Riccardo Cappato. Buongiorno, Riccardo. We have Professor Snezhitsky from Grodno, from Belarus. We have Professor Aras Puodziukynas, Kaunas, Lithuania. Good afternoon. Good morning still. Professor Kanorsky from Krasnodar. I believe that at a later stage we'll have Yjuri Karpenko from Odessa with us. At this point he's somewhere else. Irina Zotova, good morning. Very pleased to see you. She's from Moscow. And Dr. Knygin, we've had a replacement in our team, substitute, and just a bit later there will be the participant number 7 announced, who will conclude our today's conference. Esteemed colleagues, gentlemen, ladies and gentlemen, I've invited you here to that end so that we can try and clear up the very important issue for practicing GPs and cardiologists. What is the most adequate, what is the most reasonable way for us to help patients with AFib that have undergone the radio frequency ablation procedure, catheter ablation? Today here with us we also have simultaneous interpretation. Yuri Burdunkov is a great guy, I've known him. He's from Minsk. We're pleased to welcome him and we appreciate his help and support during today's webinar. I would like to give the floor to the first presenter of the day. Please allow me to introduce Professor Riccardo Cappato. Riccardo, the floor is yours.
Thank you very much, Andrey. Thank you for inviting me. It's a great pleasure to be here this morning. Ladies and gentlemen, my topic is role of ablation in the treatment of atrial fibrillation. Are there reasons to distinguish between short-term and long-term post-ablation period? These are my conflicts of interests. Catheter ablation is increasingly being used to treat drug-refractory atrial fibrillation, but recurrences after initially successful pulmonary vein isolation are common. During the first 3 months after ablation, a substantial proportion of patients experience early recurrences of AF, to which we refer to as ERAF, or other atrial tachyarrhythmias, to which we refer to as ERAT. The relevance of ERAF or ERAT in predicting long-term recurrence risk is controversial. ERAF are believed to often be because of transient local inflammatory states and associated with the risk of later AF recurrence, and thus do not necessarily represent treatment failure. Therefore, it has become common practice to use a post-procedural blanking period during which AF recurrences are considered non-specific and do not prompt intervention. So let's move first to the definition of early and late post-procedural recurrences of atrial fibrillation. ERAF has been defined as any recurrence of atrial fibrillation longer than 30 seconds during the first 3 months post-ablation. ERAF is to be distinguished from late recurrence of AF, to which we will refer to as LRAF. LRAF has been defined as any recurrence of AF longer than 30 seconds between 3 and 12 months post-ablation. For the sake of simplification, ERAF and LRAF are used, although it is recognized that early or late recurrences include atrial flutter or atrial tachycardia as well. Among hypothesized causes of ERAF are inflammatory changes owing to energy delivery, regardless of whether this is RF or cryo or any other form of energy, incomplete isolation of pulmonary veins, recovery of previously isolated pulmonary veins, modification of the autonomic nervous system triggering new arrhythmias, and delayed effect of delivered energy due to tissue consolidation. The first documentation in the literature of ERAF was provided by Oral and co-worker in 2002. In their experience, they proved that during 60 days post-ablation, there was a progressively increasing proportion of patients that were experiencing a first recurrent episode of atrial fibrillation. After about 30 days, the curve reached a plateau to the level included between 40 and 50% recurrence rate of atrial fibrillation within 3 months from previous ablation. Patient characteristics in oral population included a mean age of 53 years, overwhelming proportion of patients, 85%, and of paroxysmal atrial fibrillation, also 85%. A mean duration of AF prior to ablation of 7 years. A very high frequency of AF per month, at least one every second day. A normal left ventricular function, and a slightly increase of the mean left atrial size, 41 millimeters. So we could say this is a typical patient population belonging to paroxysmal idiopathic atrial fibrillation. In their experience, they also showed that the larger proportion of patients experiencing early recurrence of atrial fibrillation was contracted within the first 3 days. However, recurrences of atrial fibrillation could be observed at any other day in the following scale until 14 days. And here is the most important message that was first delivered by Oral and co-workers and led the medical community to appreciate that patients experiencing early recurrence of atrial fibrillation would be at a much higher risk of experiencing atrial fibrillation recurrence during the intermediate to long-term follow-up as compared to patients who would not experience early recurrence of atrial fibrillation. However, another important message from this study was that among patients with early recurrence of atrial fibrillation, there was a considerable proportion in the range between 20 and 30% who would not experience any further atrial fibrillation during the long term. So it was clear from the very beginning that the meaning of the blanking period comprised between 0 and 3 months would identify a proportion of patients with a recurrence of atrial fibrillation that would not experience atrial fibrillation any longer thereafter. We tend to refer to this phenomenon as to delayed efficacy in patients with ERA. O'Donnell and co-workers in 2003 were the first to report between patients with acute cure versus patients with delayed cure. Out of a total amount of 50 patients, 24 experienced acute cure, meaning they never had recurrence of atrial fibrillation, neither during the blanking period nor thereafter. whereas delayed cured was referred to those patients who experienced atrial fibrillation during the blanking period, but did not do so any longer thereafter. Failure included patients who developed recurrence during follow-up. As you may appreciate, the three populations were almost superimposable in terms of age, whereas patients with delayed cure tended to present with a longer duration of pre-procedural atrial fibrillation expressed in years, 7.1, versus 3.1 in patients with acute cure. Then the total figures in the three groups here were too small to appreciate substantial changes in other investigated parameters. However, it is noteworthy that the left atrial size in the population with a delayed cure and with failure was at 45 and 46 millimeters maximum transverse diameter at the long axis projection, much higher than the mean left atrial size observed in the acutely treated and effectively treated population, 38 millimeters. The authors also focused their attention on signals that could be appreciated on the surface EKG, and particularly the P wave duration during the pre-procedural phase and during follow-up, and the P wave dispersion. Patients with delayed cure tended to have longer P wave duration and P wave dispersion than patients with acute cure. And most importantly, and in comparison to patients with failure, tended to benefit in terms of reduction in the duration of these two parameters at 3 months follow-up. So at the end of this study, it became evident that about 40% of patients who have early recurrence of atrial fibrillation may benefit of delayed efficacy. And this was the first attempt to try to identify patients with early recurrence of atrial fibrillation, both present in the delayed cure and in the failure cure, to distinguish them in terms of those who will not experience any further atrial fibrillation after 3 months versus those who will experience it. Is there a role of early reablation in patients with ERAF? So some authors have investigated whether an early recurrence of ERAF would prompt from immediate reablation before the end of the blanking period. In this study, produced by Andrade and co-workers in 2012, the authors were investigating the freedom from recurrent AF in the ordinate over time from index ablation procedure in the abscissa. As you may appreciate, and similar to what observed in the previous study by O'Donnell and co-workers, about 40 to 50% of patients would develop early recurrence of atrial fibrillation during the blanking period. If early reablation was performed immediately upon observation of early recurrence of atrial fibrillation, but after the end of the blanking period, those patients with early reablation and previous ERAF would perform similarly to patients who never experienced any ERAF throughout their blanking period. And these two outcome survival curves, free of recurrent atrial fibrillation, would perform significantly better as compared to patients with ERAF. At that point in time, the investigators were particularly interested to identify the predictors of early recurrence, late recurrence, and late recurrence after early recurrence. Male sex was the only predictor for early recurrence. Current tobacco use and left atrial size was the only predictor for late recurrence. And clearly, current tobacco use, left atrial size remained predictors when late recurrence after early recurrence was analyzed. But in addition, also coronary artery disease, previous myocardial infarction were predictors of late recurrence after early recurrence. Importantly, as we observed in the previous curves, early reablation was a protecting factor and actually led to a significant risk reduction in the likelihood of experiencing future events. Does the role of ablation design influence the probability of early recurrence of atrial fibrillation? This important question was addressed in the STAR-AF trial, which, as you may remember, published in 2015, proved that in patients with persistent atrial fibrillation, selection of any of these three ablation designs, pulmonary vein isolation alone, isolation plus electrogram ablation, or isolation plus lines, did not result in different survival curves free from atrial fibrillation. In this sub-study of STAR-AF, Andrade and co-workers were investigating the role of ablation design in the incidence of early recurrence of atrial fibrillation. So 3 populations were identified overall in a sub-study, totaling 100 patients. And the patient populations receiving PV isolation alone, PV isolation plus CAFE or CAFE alone were similar, with the exception of the procedural duration, which clearly was longer as more energy was applied according to the ablation design. Uni and multivariate analysis was performed in search for predictors of early recurrence, late recurrence, and late recurrence after early recurrence. So late recurrence after early recurrence is the most attractive element of our discussion today. And as you may appreciate, left atrial size, use of antiarrhythmic drugs within the 3-month post-ablation period, use of CAFE plus PVI, and use of PVI versus PVI plus CAFE were found to predict late recurrence after early recurrence. So the study, as previous studies showed, was very clear in showing that if patients did not develop any early recurrence, they had a better outcome as compared to patients with early recurrence. And as you may appreciate, this is a very reproducible finding. If we excluded the blanking period of 3 months and we investigated the role of ablation design depending on the absence of early recurrence, then patients receiving PVI plus CAFE showed some better benefit in terms of freedom from late recurrence as compared to the other 2 groups. Whereas patients without ERAF did not show any significant difference if they only received PVI isolation or PVI plus CAFE. And patients with ERAF, they had better benefit if they had PVI plus CAFE as compared to the other 2 populations. To me, this finding is somewhat contradictory with the general outcome survival curves, as what we appreciate is that according to an intention to treat, the three different designs did not appear to show different outcomes regardless of the situation during the blanking period. The role of time of the last ERA within the blanking period was recently investigated to show whether it would play any role in terms of predicting later outcome. This question was addressed in a recent study by Willems and co-workers, who investigated patients depending on whether the month of the last early symptomatic atrial tachyarrhythmia was very shortly after the procedure, within the first 30 days, intermediate, between 30 and 60 days, or late, after 60 days, and before 90 days. And as you may appreciate, the shorter the month of the last early symptomatic atrial tachycardia or tachyarrhythmia, the higher the probability that the post-blanking period would be associated with a good outcome free of atrial fibrillation recurrences. I think this is correspondent to an intuitive concept, which is the later the last episode, the higher the probability that the post-blanking period will be affected by other events. And the same applies here if one considers atrial fibrillation only. So here reported is the freedom from late recurrences depending on whether the last episode of early recurrence was recorded during the first month, 62%, during the second month, 36.4%, or during the third month, 7.8%. In summary, Mr. Chairman, ladies and gentlemen, the studies that have been conducted so far in the literature are not of sample size large enough in order for us to come to conclusive evidence in relationship with the predictors of RRAF in patients with ERAF. However, we can roughly summarize the current findings by saying that among clinical characteristics possibly influencing the predicting role of ERAF for patients who will continue to experience recurrence of atrial fibrillation after the blanking period include older age and non-paroxysmal atrial fibrillation type. Among characteristics of early recurrence atrial fibrillation, those being experienced later in time within the blanking period, patients with multiple episodes, and patients with later timing will be those having the highest probability of experiencing post-ablation, post-blanking period atrial fibrillation. Among procedural characteristics, incomplete PVI, AF inducibility, electrogram-based ablation, lack of atrial fibrillation termination during the procedure have been suggested as possible predictors of late recurrence of atrial fibrillation. Whereas among imaging characteristics, increased left atrial size or volume appear to play a role. In terms of treatment strategies, the evidence available shows that under antiarrhythmic drug use, patients experience reduction of ERAF episodes during the blanking period, of reduced cardioversion during the same period, and of reduced hospitalization. There is, however, no evidence suggesting an effect of early antiarrhythmic drug treatment to prevent late recurrences after blanking periods. Corticosteroids and colchicine have also been used, showing reduction of acute post-ablation inflammatory markers and possible reduction of ERAF episodes during the blanking period for the former, and reduction of ERAF episodes during the blanking period for the latter. However, there is no conclusive evidence for both drugs that lead to positive influence on the probability of experiencing late recurrences. In conclusion, the relevance of ERAF in predicting long-term recurrence risk after AF continues to remain controversial after 20 years of investigation in the field. The significance of ERAF in this regard appears to be dependent on patient selection, type of therapy, operator, and center experience or other confounders. Time of last ERAF within the blanking period appears to be a strong predictor of late recurrence of atrial fibrillation. And finally, use of antiarrhythmic drugs, corticosteroids, and colchicine shown beneficial effect on the prevention of early recurrence of atrial fibrillation, but lack evidence in favor of preventing late recurrence of atrial fibrillation. Thank you for your attention.
Спасибо, глубоко уважаемый Рикардо.
Thank you, esteemed Riccardo, for your presentation. Dearest colleagues, I encourage you to join the discussion of the report that you have just listened into. Does anyone have questions? Unfortunately, Professor Cappato will need to leave us quite soon. He has 10-15 minutes at the maximum. So if we make use of this opportunity to talk to renowned experts, now would be the time to do so. Dear Andrey, I've asked my question in the chat box. Do you want me to voice it? Yes, of course, it will be much appreciated. So I have a question to Dr. Cappato. Well, first of all, gratitude for the amazing report. It's great. We're so happy to see you joyful, alive, and kicking. Thank you so much for delivering this lecture. My lecture is this. Do you yourself use antiarrhythmics, AADs, during the ablation, periprocedurally, or you cancel AADs in this point? Periprocedural, peri-ablation. So does AAD influence the electrophysiology of atria? Does it help or does it prevent? So your opinion is highly valuable to us. Could you please share it?
Thank you very much. I think this is a critical point. And I think we have to be flexible in the use of antiarrhythmic drugs in preparation of the procedure. Patient selection plays a role, in my view, to limit the risk of complication and increase the probability of success. I mean that if we select patients with paroxysmal atrial fibrillation or with persistent atrial fibrillation and a limited disease of the heart, I intend an ejection fraction above 40%, a left atrial size, maximum transverse diameter of 55 millimeters, then we increase the probability of a successful procedure and of a free of complication procedure. In these cases, working on a substrate free of confounding interaction by any antiarrhythmic drugs is a true advantage. The only exception in my experience is if the patient has persistent atrial fibrillation that is refractory to antiarrhythmic drugs and refractory to previous electrical cardioversion performed before the procedure. In that case, we are aware that during the procedure, we might have trouble to maintain the heart in sinus rhythm. And to isolate pulmonary veins in sinus rhythm has some advantages. So the use of antiarrhythmic drugs in this population of preventive antiarrhythmic drugs in this population is helpful. However, we should be aware that when PV isolation is reached in patients under antiarrhythmic drugs at the time of the procedure, there might be a probability that some of the effects is linked to the concomitant intervention of antiarrhythmic drugs on the electrophysiological substrate. So I would be a little bit more aggressive in these patients to deliver radiofrequency pulses, and I would give a confirmation or 2 confirmation pulses at every ablation site in order to maximize the probability of PV isolation determined by the lesion and not by the contribution of the lesion and the antiarrhythmic.
Yes. Could I ask a question, please? Yes.
Да, пожалуйста, Арас.
Да.
Спасибо большое. Спасибо. Прекрасно.
Thank you, wonderful.
Thank you very much for your excellent presentation. It's really very important for us for everyday practice. And I completely agree with you that we have no simple answer, like a unified answer for every patient. But in between all relapses, do you differentiate somehow relapses of atrial fibrillation, clear fibrillation, and macro reentrant atrial tachycardias, which sometimes could be very persistent, aggressive, and maybe you are doing re-ablation earlier for one group, like macro reentrant and fibrillation much later? Thank you so much.
This is another really relevant point. I like to think to atrial fibrillation as to a complex model and a probabilistic model. If that is, I'm not a mathematician, but for us as medical doctor, a probabilistic model means that we may wait for anything to happen in a model that we are incapable to comprehend in detail. If that is the case, I think you should expect any type of arrhythmia to occur after a change in the substrate that you have generated by your design. So we work for eliminating the occurrence of the arrhythmia. But if we fail, any kind of model of arrhythmia can be generated as a consequence of the changes that we have determined. We, for example, know that if we expand the area of ablation around the pulmonary vein ostia, away from the ostia themselves, we tend to refer to this technique as to wide circumferential ablation. We then improve the probability that recurrences of cardiac arrhythmias in the left atrium will be regular and will be so-called left atrial flutters. We know that if we stay at the ostium, then recurrences will more likely be of the type of chaotic atrial fibrillation. So I wouldn't expect any specific form of atrial arrhythmia not to occur after we have ablated the substrate, which keeps our mind open, first of all, to accept recurrence, second, to support patients in the psychologically difficult phase of experiencing a recurrence in spite of their sacrifice to undergo ablation, and third, to design the best strategy to tackle that specific pattern of recurrence, not the single arrhythmia, but how often does it come, how long does it last? Is it just one type of tachyarrhythmia? Are there different types of atrial arrhythmias? Use of antiarrhythmic drugs during the periprocedural phase and the blanking period, to me, is very important because I believe in inflammatory changes and I think they may interfere with the complex substrate. So I would rather wait for the clinical picture to show me its entire potential once fibrosis has been developed and matured within the substrate of the patient. Then I know that the substrate I have in front of me is most likely responsible for the clinical picture that the patient is presenting, and the arrhythmia is challenging to me. And then I would design my strategy depending on the clinical picture at the mature post-procedural outcome. And this could comprehend antiarrhythmic drugs or a second ablation. And the second ablation would be guided by the reading of the clinical and electrocardiographic picture that has been presented to my attention after the blanking period.
Perfect, and thank you very much. Have a nice day.
Thank you.
Спасибо большое, глубоко уважаемый Рикардо.
Grazie mille, Riccardo. Thank you very much for your presentation, for your report. We are proceeding next per our agenda. The next person to take the floor is Professor Kanorsky, Sergey Kanorsky from Krasnodar. He'll be talking about drug-assisted treatment of antiarrhythmic for the AFib patients in the short-term and long-term periods after radiofrequency ablation. Colleagues, I'm very pleased to welcome all the participants of our today's webinar. I have a very tough mission, no evidence or lack of evidence, and I'm supposed to talk about antiarrhythmics in late and early post-RFA period. So definitely a question comes up among patients and among inexperienced doctors. Why would we prescribe these AADs to patients eligible for catheter ablation? These AADs, as the patients hope, they are supposed to treat them from AF. And they seek salvation in the catheter ablation. However, the recurrence is very frequent, almost 50% after the blanking period. Late recurrences 3 to 12 months after catheter ablation. So the use of AADs and catheter ablation are not mutually exclusive. As Dr. Cappato already said, they should be used concurrently. This will give better outcome. Moreover, if the patients were treated with AADs, they can become effective after the catheter ablation, as our practice goes to show. A few words about what's happening in the left atrium after the impact of cryo or radiofrequency ablation. Yes, there is mechanical and thermal damage, there is inflammation, there is a post-ablation inflammation. There is increased pressure in the left atrium in its dilation. Arrhythmogenic substrate increased susceptibility. The left atrium tissue suffers. AF causes AF. So there is remodeling, there is electrophysiological issues. There is a hope to use AADs in the first 90 days, that there will be fewer recurrences in the use of AADs in the blanking period. The blanking period was already mentioned by Riccardo Cappato. This is the first 90 days. This time frame features unique pathophysiology of early post-ablation atrial tachyarrhythmias. As Riccardo already said, other non-arrhythmic methods do not work. However, class 1 and class 3 AADs can block sodium and potassium channels, can prolong the effective refractory period, can reduce heterogeneity, and also boost the action potential of atrial myocytes. So basically, this can even block the new recurrences of AFs. Antiarrhythmics in the blanking period. Riccardo mentioned that. It's a tough question. We need to look closely who these patients are, what kind of patients there is. Some may benefit from AEDs, some not. Amiodarone before RFA can contribute to higher success of ablation. It will increase the duration of AF. It will reduce the number of identified sections of complex of KFAE in atria. This is the randomized clinical trial, one of the few, how amiodarone performs. 206 patients benefited, were randomized into amiodarone and placebo, 8 weeks, follow-up 6 weeks. Blanking period, first 90 days, you can see that there was more patients on amiodarone free of atrial fibrillation. However, in 6 months, there was no statistically significant difference. This is paroxysmal and persistent atrial fibrillation. We are of the opinion that persistent AF needs more drug treatment, particularly amiodarone treatment. Another large randomized trial, we doubt that it can be extrapolated to the European, to Caucasian race. It was done among the Japanese patients. However, 2,000 plus of patients with AF in Japan were receiving AEDs, mainly 1C class, 90 days or no AEDs. They were mostly using, like I said, the 1C class. 1C class is traditionally used in Japan, but not in the rest of the world. And it was shown in the first 90 days, antiarrhythmic therapy contributed to lower recurrence of AFs. There were more patients free of AF. However, after the AEDs were canceled, there was no trace effect of this 90-day therapy. There were similar curves. As Riccardo already mentioned, that we know that full well ourselves, patients who are free of atrial tachyarrhythmia will benefit. This is the large American database, patients that were receiving AEDs in the blanking period, fewer hospitalizations for any cause among those patients who were receiving class 1 and class 3 AEDs. After 3 months, 44% of patients' AEDs were canceled. I mean, the doctors were trying to look the outcomes of the ablation per se, longer duration of treatment with AEDs, and there was a concern about side effects or adverse reactions, adverse events at the background of taking these AEDs. Right, so short-term therapy, 90 days after catheter ablation, is mostly useful than harmful. It does not rule out, it does not prevent late recurrence, but early recurrence is reduced. Fewer hospitalizations on AED therapy. Class 1 and class 3 are just several molecules. There were some comparative head-to-head trials of pharmaceuticals, amiodarone and propafenone. They are recommended to preserve sinus rhythm in patients with atrial fibrillation. However, we know that amiodarone used to win in a certain situation. Possibly, amiodarone is also an anti-inflammatory agent, and it reduces the symptomatic impacts on the heart. And most likely, its long-term use will be, short-term use will be more beneficial than long-term use. Amiodarone showed superiority over propafenone in the blanking period, more patients AF-free than patients on propafenone. In longer term, amiodarone was not causing more, in the blanking period, amiodarone was not causing more side effects than propafenone. How come it happened? Well, most likely this mild anti-inflammatory effect comes into play. It has a non-competitive anti-adrenergic effect. It enhances the action potential better than propafenone. It's an optimal way to reduce the cases of AF. Also, there is data among patients with surgical ablation. Amiodarone does work. However, there is a dysfunction of thyroid and potential pulmonary fibrosis that can prevent long-term treatment. We don't know what's going to happen if the patients are on therapy with amiodarone for more than three months. There's no trials like that. So we do hope that antiarrhythmic therapy is most likely going to benefit. However, should we prescribe amiodarone to all the patients out there? Most likely not, because long-term treatment causes side effects to manifest. Younger patients refuse from using amiodarone because they know that there are side effects, or they experience fatigue, reduced appetite. Some have early onset of thyroid dysfunction. In this case, antiarrhythmics of first class will be beneficial, especially if there is no cardiac pathology other than that. So also, there is a significant lack of large prospective randomized clinical trials with quality of life assessments so that we could determine what kind of treatment should be prescribed to patients post RFA. Amiodarone is definitely organ toxic. Drenidarone shows that. This is the Athena trial. It's a major trial with sub-analyses. Drenidarone indeed contributed to higher freedom of recurrent AF among patients that were undergoing catheter ablation. However, the frequency of events of primary endpoint, this is first hospitalization for cardiovascular disease or all-cause mortality, was the same in patients that were receiving drenidarone and placebo. So there was no difference between drenidarone and placebo. 90% of patients were receiving AEDs before ablation, 68% only remained after ablation, and in 1 year, fewer and fewer patients are receiving antiarrhythmics. First, partly it is caused by the fact that the benefit from the ablation procedure itself comes to manifest at a later stage. Mechanisms of early and late recurrences of atrial tachyarrhythmias. The thing is, early and late ARAF and LRAF mechanisms differ. And as Riccardo has said, and I possibly will repeat himself, there might be a second ablation, a reablation after the first one, because the first one might not yield enough efficiency. The reablation will contribute to better effect. However, there is no efficient removal of these bad factors or bad consequences after, or in case of antiarrhythmic use. So there are huge consensus papers. This is the working documents of European Heart Rhythm Association ERA. It's temporary routine prescription of AEDs in early post-ablation period can be suggested as a potential preventative strategy for recurrences of AF. However, the feasibility of beginning or continuation of AED trial in this period is unknown because of the lack of large RCTs. So, dear colleagues, let us jump on this opportunity. Let's have a look at the 2020 text of ESC guidelines. What do they have to say about the diagnosis and management of atrial fibrillation? What does it say there? Basically, follow-up monitoring after catheter ablation should be very thorough. Catheter ablation benefits and symptoms of the patients should be reconciled to try to figure out what's actually happened to the cardiac rhythm. The post 1 month recurrence is a predictor for later recurrences to follow. Some patients complain that there are some disruptions in heart rhythms, but sometimes it's mostly extrasystole or some other non-persistent arrhythmia. Also, there is symptom-free AF post-ablation, so we need to clearly consider and distinguish what the patients feel and what they don't feel, but they still have it. So, Holter, EKG, wearables, possibly even smartphones, external or implanted loop registrator, they could be used. Patients should be followed up thoroughly within the first 3 months and then annually. Antiarrhythmics from 6 weeks to 3 months can be prescribed, and they will reduce the number of ERAFs, reduce the number of rehospitalizations and cardioversions in this period. This is obvious benefit of antiarrhythmics. However, convincing proof that such treatment is necessary is lacking. This is simply non-existent, let alone lacking. forget lacking. I also think that there is this rational phase. After the blanking period, AADs can be discontinued completely, or continued, depending on the symptoms and the rhythm status. The recent data shows that patients that were receiving AADs and were AF-free at the end of the blanking period, the continuation of antiarrhythmic therapy reduces the number of arrhythmia recurrences. And there is a reference, there is a link to trial. So this is the proportion of patients with AF post-ablation that were using AADs after the blanking period within 1 year after the procedure, 3 to 12 months after the procedure. So these are the principles of AAD therapy in case of AF. No changes, same stuff from 2016. It's migrated to 2020, like word for word copy paste. Antiarrhythmic therapy goes to reduce the symptoms of AF. It is targeted, or it is geared towards the reduction of AF. The efficiency of AADs to sustain sinus rhythm is not high. However, the number of episodes can reduce, number of recurrences can be reduced, although not eliminated. If one antiarrhythmic drug does not work, possibly another one might bring benefit. Oftentimes, there are side effects, like pro-arrhythmic effects, extracardiac side effects. So in this case, the clinicians must be looking at safety first and then efficiency. Next up, some new provisions that were not there in 2016. The decision to start long-term AAD therapy is taken by the doctor depending on the burden of the symptoms that those IADs are supposed to target, and possibly also some possible side effects should be considered, and preferences and desires of patients should also be considered. 2020 shows the preference of the patients should not be discarded. This is a new thing. The AEDs that were inefficient before the ablations can be continued. There is a higher probability that they will work better. However, if AEDs are cancelled during the blanking period, the patients will be unprotected from occurrences at a later stage. Short-term AED therapy can be reasonable in patients with increased risk of side effects on AEDs, and in patients with low supposed risk, low assessed risk of AF. Definitely persistent AF will be higher recurrence danger than paroxysmal one. These are the principles for the prescription, for prescribing AEDs. Amiodarone can be recommended widely. There is a significant evidence base, class 1A, dronedarone. However, amiodarone is highly cardiotoxic. Possibly other AEDs can be considered. So safety is key. I mean, the prescribing amiodarone for many years to come for young patients is most likely harmful than beneficial. Dronedarone is not prescribed in Russia, so I will not talk too much about that. Flecainide and propafenone are different pharmaceuticals, but they can be prescribed for long-term rhythm control in patients with AF, normal LV function, without structural heart disease, including MI. In patients with AF on sotalol, thorough QT interval monitoring is recommended. Potassium, blood potassium, creatinine clearance, because sotalol is excreted through kidneys unmodified. So kidney function is to be monitored. Next, flecainide, same as other 1C class pharmaceuticals, should be concurrently used with AV node blocking pharmaceuticals. This is about the atrial fibrillations. So more comfortable cardiac rhythm, ventricular rhythm for the patient. Sotalol can be a long-term treatment option for patients with normal LV function, with ischemic heart disease, or if there is thorough QT interval monitoring blood serum potassium, creatinine clearance, and other proarrhythmic risk factors. Amiodarone and cetalol are not recommended, but beta blockers should be used in patients with persistent AF. A few other statements from 2020, the guidelines. AAD in general. So these principles are likely to match, or likely to be a good fit for patients post-catheter ablation. Severity of symptoms, we need to look at that. So what does the patient benefit from more? Will he benefit from suppressed effects of ablation, or there will be side effects? There will be some additional factors such as heart failure or other cardiac diseases that will guide our choice. Proarrhythmic risk should be brought. Proarrhythmic risk and organ toxicity can be reduced through monitoring initial baseline deviations like EKG, QRS, PR, QTC, and antiarrhythmics. The QT should not be extended by more than 25%. 500 milliseconds should not be broken. This threshold should not be broken. QRS should also be limited within 25%. Antiarrhythmics are not supposed to affect LVEF. The left ventricular function should be assessed, repeated plus some pharmacokinetic and pharmacodynamic effects should be studied. Proarrhythmic factors can manifest over time. How do we minimize proarrhythmic risk? EKG must be assessed post-treatment. More than that, if patients are on amiodarone, thyroid toxicity should be excluded. The TTH should be assessed in the blood. Plus thoracic X-ray to rule out pulmonary damage. 1C class, also the physical test, long-term Holter monitoring and exercise test in some cases can help minimize proarrhythmic risk. And combination of AEDs should be avoided, especially if there are of one and the same class. Two drugs of class 1 or two drugs of class 3 are incompatible. The efficiency of treatment should be assessed. The patient should be RLI. They should keep diaries and talk about that, present that to the doctor. If the patient was on AEDs before and it was efficient, but it was cancelled because of the side effect, then a different AED from the same class should be picked. Most likely it will be efficient. Adjuvant interventions and hybrid therapy. Just a few words about that. In the guidelines, patients with an implanted cardiostimulator, they can receive any AED. However, if the device is not to be implanted, there are issues with atrioventricular conductivity, then the AEDs can become a problem. And just one line for short-term therapy of AEDs in patients post-catheter ablation. Short-term treatment, short-term therapy with AEDs can contribute to reduced risk of ERAFs. Just a few words, colleagues, if I may. My own opinion, possibly, I will contribute that based on the trials, contemporary trials. 1C class AEDs, what do we think about them? Mostly negative. Flecainide, encainide, and morsazine, post-MI, they increase the risk of mortality and sudden cardiac arrest. However, in IHD, this is in patients with IHD, the outcomes of this treatment is understudied. This is the survival of patients with IHD, with AF. Patients were on 1C class. Patients were excluded with typical exercise, typical effort angina, history of MI, coronary vascularization, and so on. The blue 1C class AED is higher than without. However, we see a trend even in the small sample. The AEDs of class 1C in selected patients bring benefit. So several years have passed after the trial I've presented. However, there is a need for a large trial to study safety of 1C class antiarrhythmics. There are some interesting trials. Flecainide versus flecainide plus metoprolol versus metoprolol alone. Inclusion criteria: paroxysmal persistent AF and recently restored sinus rhythm. Patients with acute coronary syndrome were excluded. Patients with LVEF, heart failure, class 3 and 4, LVEF lower than 40%, atrioventricular conductivity, and severe bradycardia were the exclusion criteria. Metoprolol was a significant underdog. Flecainide monotherapy was a bit better, but it's not well tolerated. This is actual practice. Half the patients are receiving beta blockers together with some AEDs, and the tolerability of treatment is much better. Possibly beta blockers can even benefit the prognosis of patients on 1C antiarrhythmics. This is the disposition of the government of Russian Federation that allows some categories of patients post-catheter ablation to receive 1 year free of charge duration treatment course if these drugs belong to one of the 23 INNs. Flecainide is not available in Russia. Well, etesizine that's available in Russia, it is similar to flecainide. They extend QRS, and this is a pro-arrhythmic factor in some situations. Amiodarone is on the list as well, but high organ toxicity and long-term treatment is a limiting factor. Lopaconitine hydrobromide. There are some subjective neurological side effects on lopaconitine hydrobromide. Propafenone and sotalol. On propafenone, we don't really know the number of patients of one cytochrome in the liver. There could be hepatotoxicity in several patients, very limited, several percent of these patients, and can cause liver toxicity, which is a bad thing per se. Sotalol increases the QT, pro-arrhythmic factor, plus kidney function can suffer. The correction of the dose might be required. Bronchospasm is possible because it's a non-selective beta blocker. And well, the extended QT pro-arrhythmic factor is a major problem, is even more significant. The fact that Alaforte appeared, the extended release in Russia in 2017, lopaconitine hydrobromide is much better tolerated, without side effects typical for the traditional allopurinol. Conclusions. Well, whether atrial fibrillation is treatable in the majority of patients with catheter ablation alone, this is an undecided topic. Most likely, the answer today is no. I mean that the development of catheter ablation methodology can improve the share of cured patients, bringing it closer to 100%. Long-term AADs after the blanking period, can they benefit AF? Can they reduce AF post-catheter ablation? Most likely, yes, but this is still to be proven in RCTs. We can also say that catheter ablation and antiarrhythmic therapy are not competitive. These are two warriors that fight alongside against the same problem, against atrial fibrillation. And definitely the 2020 guidelines underscore that patients should receive comprehensive treatment. The underlying disease should be treated. Obesity, diabetes mellitus, hyperdynamia should be handled. However, hyperdynamia is also bad. Too much movement is arrhythmogenic. So comprehensive treatment, again, Riccardo Cappato mentioned it himself. It's atrial fibrillation is a comprehensive problem, so it should be treated by multiple ways. We should target the entire pathogenesis, not its individual links. Thank you for your attention.
Сергей Григорьевич, за ваше сообщение.
Thank you, Sergey, for your presentation. One thing I wanted to point out, we have completely disregarded a huge stage in the history in Russian pharmacology back in 1980s, when the former Soviet Union offered a whole number of antiarrhythmic drugs to the global community. You've mentioned one of these agents, lepaconitine hydrobromide. You mentioned one of these today, but what about diethylamine, toxicarbonyl, carbonyl hydrochloride, so etesizine? So this is a full-blown Paracelsus. I mean, etesizine. So what is its role? It couldn't have been featured in the CAST trial. It was not there, obviously. So what can you say with respect to the prospects of these specific agents? Why, in contrast to alapanin, it did not land on that federal free-of-charge treatment list? Well, it's difficult for me to say why etesizine didn't make it to that list. I could not have a say in that, obviously. But proceeding from safety concerns, 1C class safety, QRS extension, lepaconitine hydrobromide is safer in that respect. It is as efficient as etesizine, but it does not extend QRS as much. There's not a single statement that shows ventricular arrhythmia on lepaconitine hydrobromide, although it is possible in etesizine, and our practical empirical shows that, empirically proven. So huge doses of that stuff can extend QRS, etesizine, and this might bring about problems with ventricular tachycardia. Thank you very much. I beg to disagree, because the comparative trials with etesizine and lepaconitine hydrobromide, there were no head-to-head trials, including the assessment of their efficiency in patients with atrial fibrillation. The traditional approach that is always discussed in 1C when there is 1C antiarrhythmic is prescribed, we all know that full well. It's patients free from structural cardiac pathology. I have a question to all the attendees here. One sentence report, literally. One sentence response. Professor Puodziukynas, who is that problem? Who is that person? Who will benefit from 1C class after AF procedure, hypothetically? So who is that patient without structural pathology? Well, same as everyone, no scar, no MI, no acute ischemia, and no hypertrophy, no hypertrophic left ventricle. The rest is details. I mean, if there are no contraindications, we prefer that, because all in all, there's fewer side effects. What if that patient had an MI? There was a history. However, it's not Q effect. So no Q formation. So what can you say in that case? Is that patient going to be a candidate? Yes, thank you. Not at our clinic, not in our clinic, because for a fire to break out, sometimes just one spark is enough. And I mean, even a small necrotic lesion, not even necrosis, but a transitionary or the transition zone from necrotic to surviving tissue. There is indeed substrate for this for the torsade de pointe. So yes, there is a possibility of that. Esteemed colleagues, we have clinicians, experts here who are in charge of major institutions. Viktor Snezhitsky, your standpoint on class 1C of etesizine, for example, something that you know full well. Lepaconitine hydrobromide can also be discussed. In patients with, so to speak, with structurally normal MI, so non-Q penetrating MI, will that patient fit that cohort with some minimal heart failure symptoms? According to your clinical practice, which definitely is empirical in most of us. Could you please share your view? Good afternoon, dear colleagues. Indeed, the patients that you have categorized right now are not among those that are structurally normal heart-wise. I mean, no apparent cardiac pathology. Can you hear me? Yes, we can hear you loud and clear. Perfect. Okay, that's for starters. Secondly, who would be safe to prescribe 1C class AEDs? It's patients without obvious heart diseases, but there is atrial fibrillation, AFib, post-RFA patients, possibly with some initial stages of arterial hypertension, without manifested myocardial hypertrophy. So in this case, we prescribe class 1C. If there are other problems such as cardiomyopathy, well, these 1C class should not be prescribed. My question to the esteemed professor, should I ask them right now or later? No, we will wrap up the structure normal myocardial infarction first. Irina, your opinion. Can we prescribe 1C class drugs to patients with minimal heart failure manifestations, non-Q penetrating MI, history of that? So provisionally, can we categorize them as patients with, or can we deem them to be patients with not that advanced structural myocardial disease? So do they fit that description, your experience? Well, our experience is pretty much the same as my colleagues have just voiced. Indeed, a spark can result in a fire, in a flame. So any MI, any history of MI is a contraindication to prescribe AEDs. If we're trying to block the paroxysm in cardio block, well, I'm okay with that because there is a defibrillator in the monitor. But patients with any MI, any cardiomyopathy, I will not prescribe 1C class antiarrhythmics. Thank you very much. I just wanted to highlight the attention of our esteemed colleagues and those who have tuned into us and those with us live here, that the term itself, the so-called minimally modified myocardium, is very debatable. Professor Puodziukynas showed the gradations of heart failure, but there was an entire set of trials that were generated by reputable clinics with the criteria that are applicable, could be applicable to these patients. Patients in whom we suspect not that manifested structural changes in the myocardium, non-Q penetrating or Q non-penetrating myocardial infarction from the Sanchez works, it migrated to this cohort of patients. I mean, it was permitted, or at least that's what the works I've been able to pull up. Back in my residency days or postdoctoral studies, I remember there were patients with not that advanced heart failure. In the classical interpretation, say up to class 1C. However, even patients with myocardial infarction without manifested heart failure phenomena, without QMI, there was a practice. They were, back in the 90s, they were the potential candidates for 1C class pharmaceuticals, where one of the flagship drugs, totally underrated today, I think, is etesizine, plus the pharmaceutical that Sergey mentioned today. I believe that we do have some well-forgotten old friends, familiar agents that we've known a long time ago. They are severely underrated. I understand that this is a debatable statement, a discussable statement. Unfortunately, because of the time limit, we will not be able to talk about that at length. But possibly this will become the subject of our conversation in the future. Right now, let me exercise my rights as the moderator. I will give the floor to Irina Zotova, Ph.D. in medicine, patient-specific strategy of antithrombotic treatment in early and late post-RFA atrial fibrillation. Thank you, Andrey. Well, indeed, it is clear that the antithrombotic treatment as a follow-up of RFA, it demands significant discussion. We ablate patients with AFib with a high risk of thromboembolic complications. The procedure of radiofrequency ablation itself causes this risk to go up. The thromboembolic risk, the embolism risk goes up. So if a patient has a clot in the left atrium, well, a catheter introduced over there can cause this clot to migrate. For this reason, anticoagulation therapy prior to ablation is definitely necessary. During the ablation, there is endothelial damage induced by electrodes and catheters introduced into the left atrium. Remember, there was a lot of debate. Cryo or RF, any kind of ablation will cause endothelial damage. The trigger for hypercoagulation is the contact of blood with the devices, with the buildup of thrombogenic destruction lysis products. Plus, there are blood flow distortions, disorders that also manifest the thrombogenic status to worsen in patients that were subjected to the procedure. Post-ablation, the contractility is not restored immediately. For quite a while, several weeks, there is this stun effect on the tissue of the atrium. It depends on the duration of that stun stage, depends on the category of patients. Normally it takes 4 to 6 to 8 weeks, 3 to 4 to 6 weeks. This is atrial fibrillation patients we're talking about. Plus, there is some time needed for the endothelial damage that we've induced to heal. It will also reduce the thromboembolic complication risk. So indeed, it's impossible to carry out ablation without antiarrhythmics, because patients, without anticoagulation, sorry, patients that go for, eligible for catheter ablation, they will need anticoagulation. RFA and anticoagulants. So there is a whole section in 2020, but it's not that big. There are just 3 main points I would like to highlight: before, during, and after. It's reflected, but without proper, say, elaboration. So before the RFA, if the patient was not receiving an anticoagulant, they should receive a 3-week course of adequate hypocoagulation treatment, or ruling out the intra-atrial thrombosis with echo. So transesophageal echocardiography could be one way to do that. So 3 weeks of anticoagulation, at least 1 C class, or this transesophageal echocardiography. So there are some pros and cons. Patients will receive a minimum of 3-week course of anticoagulation treatment. Plus, the visualization will be performed to look for those intra-atrial clots. What are the arguments pro? There is a major work, 600 plus patients with atrial fibrillation. They were receiving direct oral anticoagulants for at least 4 weeks before transesophageal echocardiography. And even though, check this out, in 3% there was a clot in the left atrial appendage, and there was 2.5% of FSC, stage 3 and 4. Congestive heart failure was a risk factor, odds ratio 4.4, and patients with extended or increased left atrium was also higher, 3.1 hazard ratio. Cleveland Hospital, 900 patients, so one center, but still a very large sample. The patients were included or enrolled for many years, during many years. The essence of that work was also the patients were on direct OACs, but they were not receiving any additional visualization, neither before nor after the procedure. The clotting in the left atrial appendage was not looked at, but still the very risk periprocedural thromboembolic complication, 0.3%. So the experts said that it does not make sense to do the visualization because it just blows up the cost. But if there are some state initiatives or public initiatives, well, the benefits, the patients might benefit from this transesophageal echocardiography. 2017, HRS, ERA, and so on. Expert consensus statement said that transesophageal echo prior to RF should be done to all patients, regardless of whether they were on anticoagulants for the past 3 weeks. So this is interprocedural stuff. What needs to be regarded? If you're taking a decision, if you're making a decision about the 3-week course, are you going to use visualization as well? The higher the risk of thromboembolic complications, the more arguments for visualization, pro-visualization, to rule out this left atrial appendage thrombosis. However, to assess this risk, we use the traditional CHES-VASc score. High risk is 2 in men, 3 in women. Obesity, proteinuria, glomerular filtration rate less than 45, NT-proBNP, elevated troponin, T or I. Normally it's I in our case, so we'll look at that. The volume and size of left atrium increased, diastolic function of left ventricle, ABC scale. So we do not really measure the ABC because of one parameter that's missing in our case. D-dimer, C-reactive protein. I looked at neutrophils to leukocytes ratio. These are all additional risks for thrombosis, plus the lack of severe mitral regurgitation. So if for some reasons you decide to visualize, to do imaging, to look for clots after 3 weeks or 4 weeks of OACs, so you should look at these risk factors, including the additional risk factors. CHES-VASc, obviously, plus these risk factors. So most likely, if you fail to do the imaging, you will not find that clot. If you've interrupted the direct anticoagulants for 24 or more hours before the ablation, so the patients cannot be put on this ablation. Transesophageal echo should be done mandatorily. So patient-oriented model to pick anticoagulants. Class 1 of clinicians is nihilists. They say that all OACs are the same. I mean direct oral anticoagulants, direct OACs. So I'll just reach for the shelf, whatever I find there with anticoagulants. I don't care what kind of drug there is. The most importantly is the right dose. This is one extreme. Another extreme is OACs to all patients regardless of the situations. And there is the middle or some intermediary position. I am myself among these experts. There is no perfect OAC. There is a perfect doctor. So whenever I pick an OAC to a patient with AF eligible for further ablation, so I mean I'm prepping the patients for RFA, I cannot always say I can never say that there is a perfect OAC for all the patients. I will look for valvular pathologies that demand only warfarin. Just 2 criteria for warfarin alone: mechanic valvular prosthetics plus moderate or severe mitral stenosis. It's just in 2020 for atrial fibrillation, the moderate, the word rheumatic went away from the stenosis. It used to be rheumatic patients with rheumatism, but now it's any kind of moderate or severe mitral stenosis is a contraindication for direct OACs. So I've ruled out patients on warfarin, patients with high risk in Chezvesk, high score, the stroke risk, bleeding risk, hemorrhage. I'm looking at those indications, contraindications. If there are some absolute contraindications, that's end of the road. No OECs. We look at the kidney function, Cockcroft Gold, creatinine clearance, liver failure, Child-Pugh class, Child-Pugh scale is used to assess the liver failure score. Drug interactions, we're looking at that, PIL, recommendation guidelines. There are some nuances that doctors should be aware of. If your direct OAC messes with the underlying basic therapy, well, go ahead and pick another OAC. Most likely there will be no drug intervention. So look at the patient information leaflet definitely, and the guidelines. I'm also trying to identify additional therapy customization factors, age, intracranial hemorrhage, and so on and so forth. So in my practice, how do I pick an anticoagulant in patients? This is the patient-oriented model of selection of OACs to prep for RFA. Once again, there's no such thing as a perfect anticoagulant. There are perfect doctors. A 66-year-old patient, male, first AF, de novo AF, high risk of stroke, congestive CHF, with intermittent problems with ejection fraction, plus a stroke 3 years ago. So he was somewhere in the Moscow Oblast, no patient charge, no nothing. It's just a small line in the patient record. So most likely it's ischemic and hemorrhagic risk as well. Whether there was or whether there was no hemorrhagic transformation, we cannot say anything based on that single line in the record. Abdominal aortic aneurysm, history of that, 43 millimeters. It's not growing. It's not growing, and the wall of that aneurysm is paved with old thrombotic masses. So basically, an abdominal aorta aneurysm is a contraindication for OX. Creatinine clearance 67, Child-Pugh class A. So there is no limitation to prescribe any OAC. So how do we pick one for a patient like that? So indeed, there's no perfect anticoagulant. There is a customized risk assessment. So in this patient, we have a high stroke risk. Most likely, this patient will be eligible for ablation. Most likely, I mean, it's the de novo atrial fibrillation at the age of 66. However, those symptoms that we observe, plus a progressive heart failure, and most likely, we're going to send this patient to our arrhythmology colleagues. Me, as a cardiologist, I'm picking the OAC right here, right now. So how do we do that without knowing what's going to happen in the future? So there is an intact kidney function and a very early stage of liver failure. So these American recommendation, chest recommendations, thoracic experts recommendations can be used. Patients with high risk of ischemic stroke, and you remember his age, 66, history of stroke, MI, CHF. So there's a whole bunch of risk factors for stroke. So the Bigetran 150 by daily is the only drug that is superior to warfarin. But still, the bleeding risk must be carefully assessed. Indeed, of all the direct OACs, the Bigetran was superior to warfarin in terms of efficiency in all trials. This thoroughly assessed hemorrhagic risk should be about this, dear colleagues. A very practical advice on my part. Just follow the PIL, follow the instructions. If we do it on label, if we do not prescribe 150 milligrams of patients 60 plus or patients on verapamil, or prescribe the Bigetran to patients 75 to 80 years old with reduced liver, with reduced kidney function. But in patients, younger patients, 50 years old, even in creatinine clearance 30 to 50, the Bigetran can be considered. The PIL says that we can do that. If we go on label and we prescribe the Bigetran like that, we will get both high efficiency and high efficacy and high safety. A 3-line trial So gastric bleeding on dabigatran 150 on warfarin, and patients with dabigatran based on the existing actual PIL. Empirically, the 150 bidaily Medicare analysis, American database, 150 dose is used, 110 dose is not registered there. It shows high safety of the dabigatran. So there's no such thing as a perfect OAC. We have intact kidney function, early stage liver failure, class 1 Child-Pugh, and a very high risk of stroke. So we can consider the dabigatran 150 as a drug that was superior to warfarin to prevent stroke. Safety of the patients based on the PIL, and given the patient's age, we can and we should prescribe 150 milligrams. The actual clinical practice shows the safety of such prescription strategy of the patient. Even compared to rivaroxaban, the dabigatran was better. It was with the apixaban, it was comparable. Gastric bleeding was high on the dabigatran. Intracranial was lower on the dabigatran than on the apixaban. So the patient has an aneurysm. This is a relative contraindication. So dear colleagues, let's not be delusional here. If a patient needs OACs, this higher or lower, slightly higher, slightly lower risk of bleeding will not be a very big issue for the patient. Anticoagulation effect, this is what the patient should benefit from. So why did I pick this specific clinical case of customized personalized care? Patients with that in that risk group eligible for RFA. So we had a huge debate with our colleagues. So they said 150 the dabigatran for this patient. What about aneurysm rupture? But well, aneurysm dissection 110 or 150 the dabigatran doesn't matter. If there is an aneurysm dissection, apixaban or the dabigatran will not matter. We will need to select the antagonist. Idurusizumab became available in 2019. Specific antagonist. Idurusizumab is a product that stops the dabigatran's action because it completely binds the dabigatran without affecting the hemostasis. This is very important in ablation because the situation is very clot hazardous. Ablation itself is a severely thrombogenic procedure. So there are if there are any periprocedural problems and you want to stop the dabigatran action, non-specific inhibitors of fibrinolysis can cause this bleeding to stop, but the clotting will be induced and the patient might die of that. So the Russian consensus paper interprets this position as such. A patient with a specific model of selection, so presence of a specific antagonist in a specific direct OAC can be an argument to go for that pharmaceutical. Our patient has a very high risk of emergency procedures. First of all, there's an aneurysm. Secondly, we clinically assess that this patient is about to receive ablation, that's 2. And then, if that patient is sent for ablation, there won't be just that. There will be a high risk of thrombotic complication. The dabigatran in this situation gives us what? We will be able to use the antagonist if something goes wrong with the patient during the procedure, because this advantage can be key to prevent the loss of life and to maintain its quality. So the ablation itself, 3 weeks of anticoagulation at least, plus we'll reinforce those 3-week course with imaging. We rule out the left atrial appendage thrombosis. So in 2020, we see a recommendation in the guidelines without discontinuing OX. It's both for DOX and both for same for warfarin. The meta-analyses have been published, almost 13,000 patients, 29 RCTs plus observational trials, they show that direct OACs are safer in ablation patients than warfarin. So direct OACs, if there are no absolute contraindications, are pharmaceuticals of choice. When we select one, when we select the DOAC, we understand that we can do the ablation without discontinuing the direct OAC, be that apixaban or the bigatran or rivaroxaban or edoxaban, which is not available in our country so far. So these three pharmaceuticals were as efficient, at least as efficient and as safe as warfarin in these patients during the ablation, when we were not discontinuing the therapy. The bigatran was safer. There were many patients in this trial, so there was a statistical significance, there was sufficient statistical power. The bigatran versus warfarin caused much fewer severe complications. We tend to take that into account in our practice, and we're prepping the patients for ablation. Even patients on warfarin, for some reasons, they have been on warfarin for ages. And if they're looking at ablation, then we typically talk to arrhythmologists to try and switch that patient to a direct anticoagulant, because periprocedurally it will be safer. Also, this continuous anticoagulation therapy is also a big question. There is a genuine or genuinely continuous or skipping 1 or 2 doses of DOAX. Again, here we need to think about the patient. What are we going to do? Like, no doses skipped at all, no doses of direct OAC, or say in a trial with the bigatran, there were patients with the bigatran that were put on ablation 4 hours after the first bigatran dose. Same time frames in other trials. So this is the genuine continuous therapy, or skipping 1 or 2 doses of DOAX. So the selection of the strategies, genuine continuous, so skipping a couple of doses, is based on kidney function and the experience of the arrhythmologist in the center, mostly arrhythmologist is going to do this procedure. So there is this opinion that genuine continuous therapy without skipping a single dose is expedient if during the RFA the intra-atrial septum is punctured under ultrasound, or if there is an antagonist. For example, if the patient is taking the bigatran and the edaravimab is available. So no doses should be skipped. This will be genuinely continuous, truly continuous therapy. 1 or 2 doses can be skipped, and the backdrop of continuous therapy, it's still regarded as kind of continuous. The septum puncture, if it's done without imaging, without antagonists, so there is no surefire way to do that. We're patient-oriented always, and we're looking at whether it's going to be a genuinely uninterrupted or slightly interrupted therapy. Warfarin, unfractionated heparin, should be introduced intravenously, 300 to 350 seconds clotting time. The bolus, there are options, 90 to 200 IUs per kilo. So some experts say that the dose should be introduced before the septum is punctured. There is a half that say that half the experts are saying that some have the dose before the puncture, have the dose after. There are no trials that show the benefit of either of these methodologies, but still, then unfractionated heparin should be introduced. After we've punctured the septum, after we so there are 3 options to remove that introducer, to remove that. Protamine can be used to stop the action of heparin. What should you be thinking about when you're doing ablation on direct OAC? They affect the activated clotting time. Rivaroxaban demands higher doses compared to heparin. On the bigatran, there was no meaningful difference. Mean activated clotting time was 3:30 on the bigatran and 3:42 on heparin. For the bigatran, it was found that the lower the interval between the last dose of the bigatran and the puncture of the atrial septum, the better chances you have to reach the target clotting ATT. But if there is an antagonist available, because if there are any complications, it will be very difficult to counteract them. Post-procedurally, how do we resume? 3 to 4 hours after the introducer was removed, we resume the DOAC. If there are any complications, it can be postponed, but preferably not more than by 12 hours because of high thrombotic risk. There is an indirect opinion of experts that is discussed in articles. I'm not managing such patients. Maybe Andrey will contribute that. For example, if your patient immediately post-ablation has a hematoma at the introducer installation site, if it's manageable and if it's not severe, you can resume the DOACs, but it's either unfractionated heparin is the most manageable one in case of complications, or the bigatran if you have antagonists. It's a debatable issue. If there is a severe bleeding, severe hemorrhage, then yes, we should introduce protamine for non-fractionated heparin, idurosizumab for the bigatran to manage that severe bleeding. Post-RFA, I'm about to complete my report. Post-RFA, at least 1 month for that healing period, or minimum for 2 months, 1C anticoagulants. After 2 months of RFA, we prescribe anticoagulants looking at the stroke risk. Both are class 1, but the grade is C. C is expert opinion. Of course, there were no large trials on that. So, dear colleagues, just 1 second of your attention for this slide. Why am I supporting this, regardless of the success rate of the ablation? On the one hand, why did this phrase come around? Because it's impossible to do 100% efficient ablation. Report 1, report 2 of today already said that. There will be atrial fibrillation. Sometimes they are symptom-free. If they're silent, it's very difficult to detect them. So regardless of what we have after the ablation, 2 months after ablation, we calculate the CHEST-VASc score. If the score is too high, we prescribe anticoagulants indefinitely. So that's the position. Another important point, it could be conceptual in why we should prolong the coagulation therapy even after the 100% successful RFA. There is this argument of atrial cardiomyopathy. We were discussing that at our previous meetings. What kind of a theory is that? This atrial cardiomyopathy theory is interpreting this clotting in the left atrial appendage appearance. So it's ruling out fibrillation from the main pathogenesis chain. So fibrillation of AFib is it's one of the links in the chain, together with the special features of left atrial anatomy of renin, angiotensin, aldosterone system activation, RAS activation, inflammation, endothelial dysfunction. AFib is just one manifestation of atrial cardiomyopathy. Atriophysiologically, this is fibrillation or any other supraventricular arrhythmia. And there is a thrombotic criterion, ischemic stroke or prothrombotic shifts. So even if we remove AFib from the picture, we will not be able to kill the atrial cardiomyopathy. For this reason, these patients might exhibit a higher risk of stroke development. So the guideline is like this. Before the ablation, at least 3 weeks course of anticoagulants and preferably TEE. We discontinue the treatment for some time after the therapy, after the ablation, then would do the RFA on any DOAC or warfarin, and then after RFA, 2 months minimum of anticoagulation therapy. Thank you for your attention. Thank you, esteemed Irina, for your report. We have time for just one short question. I know that Viktor was meaning to ask one. Yes, good afternoon again. Dear Irina, can you please tell me? I see that you have extensive experience in looking at this, monitoring these guidelines. What is the % of complications because of the coagulation at your clinic, because of the dose of the drug? Patients post-RFA. At our clinic, RFA is not done, is not performed. I'm a cardiologist. I only prep these patients and I send them for this procedure elsewhere. Andrey is bringing these patients back to me mostly. So he's the arrhythmologist in my case. So in these patients, if we're not looking at minor bleedings, well, the complications are just 1%, less than 1%. It's very, very seldom. So not different from world statistics, definitely not. Andrey treats the most severe patients. He's doing the most tricky patients, even with thrombocytopenia, with vascular malformation. We just discussed one case yesterday. Andrey does these cases as well, patients which are very tough to prep. However, if we're looking at protocols, if we're guided by the protocols, this patient-guided, patient-centered selection strategy, it helps. Thank you so much, Irina. Let's move on. Please allow me to give the floor to Professor Puodziukynas. The next presentation will be about electric cardioversion and its role in comprehensive treatment of patients with RFA, patients with AFib post-RFA. Aras, the floor is yours.
Извините, только сейчас, по-моему, включил звук.
Right, I just figured out that my microphone was off. Thank you, dear colleagues. Our topic is indeed quite tough, quite difficult. There's no such things as simple questions there. Electric cardioversion is one of the components of this comprehensive treatments for our patients. So this is my disclosure statement, my disclosure. Whenever we're talking about any disease that we're trying to treat, we need to look and understand, look into and understand its pathophysiology to avoid triggers. So, for example, if we look at this convoluted chart that's displayed at many conferences out there, so we really do not know how this pathophysiology of AFib looks like. There are sources dating back to 1997, 1998, 2000, 2004. Check out our favorite recommendations on technology and on methodologies of atrial ablation. You see the very same charts, although 17 years have passed, more than that after some works. If we check out the most recent 2020 ESC guidelines on AFib treatment, the dominant phrase is this: mechanisms of atrial fibrillation are not yet fully understood. And as I keep saying to all our patients, this Nobel Prize is still awaiting its laureate. However, the patients are still alive, well, alive and kicking, and as long as they're that, we need to help them as best we can. Atrial fibrillation, we can combat triggers, triggering mechanisms, starters, and we can also try and combat substrate and maintenance phase. Long-standing persistent form, we should also try and help these patients. We're mostly targeting the substrate. Well, first of all, we're looking at pulmonary veins. PVs are special in their anatomy, with intermittent fibers which are being distorted, that can react in salvos, very short refractory period in these cells that causes them to do these salvos, these rounds of high frequency. These are the triggers. What about the substrate? The substrate, well, Nasir Marush, professor from Salt Lake City, can be trusted in this respect. He shows exactly how much fibrosis can be out there in the atrium that is visually or echocardiographically is all right, looks okay. If it's without visible signs, if we're not looking for those. The methodologies that are targeting ablation are either ruling out triggers or as an additional impact fragmented trying to target the substrate. So what is the place of cardioversion in this comprehensive treatment of patients? What is the role of cardioversion? So again, we are looking at practical recommendations on as to how these patients should be managed perioperatively. Cardioversion, I do the search for that one, and I found it on 29 pages. So that's quite a lot of mentions, quite a lot of. So let's have a look at terminology here. What is a failed electrical cardioversion? This is when we have been unable to restore sinus rhythm for 30 seconds or more following this EC procedure. If we have, that's already successful electrical cardioversion, but there can be immediate AF recurrence within 24 hours after cardioversion. That's immediate AF recurrence post-CV. Most often it happens within 30 to 60 minutes after cardioversion. We send our post-ablation patients normally, routinely, to the ICU ward, not because they're doing poorly, but just to monitor them properly, just to make sure everything is all right, and to respond as quick as possible to the changes in their clinical situation. Early AF within 30 days and late AF recurrence post-cardioversion is after 30 days. Again, what are the criteria of successful ablation of atrial fibrillation? Pulmonary vein isolation. This is the cornerstone of AF ablation. In these practical guidelines, 95% of authors of the writing group members, 95% use this endpoint during all AF ablation procedures. So PVI is demonstrated by entrance block alone by 95% of authors. If we're looking at articles, especially as the ablation technology develops, many authors say that they not want to see spontaneous cessation. This is the way to predict good outcomes for these patients. However, other studies have not confirmed this finding, especially if there was no spontaneous cardioversion ablation. This does not mean that there will be a treatment failure in this patient. So there is this idea that the cessation of atrial fibrillation can be not just indicative or not just indicate a successful procedure. It will show a less manifested substrate and less persistence, regardless of the intervention. Yes, it's a psychological upside. At our clinic, after any intervention we've performed, cardioversion is a must. not just to register the potentials, not just to show the entry and entry blocks, but this is also a psychological point. A patient decided to go for intervention, so they should be psychologically reversion. A sinus rhythm that will stay there for some time. When there were ablation studies performed, some were looking at more aggressive and less aggressive management strategies. Malasana at ARIA, they were looking at 1,300 patients, more than 1,700 procedures, much higher figures than other trials. And still, 39% of patients required cardioversion post-ablation. This could have happened at any time down the line, mostly within the first month, within the first 28 days. However, the vast majority of issues manifested within 90 days post-RFA. However, the majority of patients that required, so three-fourths of patients that required cardioversion were on sinus rhythm, and they discontinued antiarrhythmics 1 year post-RFA. So this is a question, or this is a matter of longer-term observation results. 3-5 years, it's a matter of follow-up. But still, this need of cardioversion, especially in the blanking period within the first 3 months, it's not necessarily a bad thing. Early recurrences are observed in about 50% of patients within 3 months after the procedure. As my colleagues have shown before, this is not just a failure. This is not a failure of the procedure per se. If we were unable to isolate the veins, or we did not find that conductivity zone, or we isolated the PV, but we failed to de facto. So again, we're explaining that to the patients. It's a condition same as after a fire, after the earthquake. Everything is in smoke, in flames, everything is in rubble. Well, it's kind of a metaphor, but still the patients should understand that there was a significant myocardial trauma that they were subjected to during the procedure. So for this reason, I was asking about the reentry. I was asking the professor about the reentry. Fibrillation is chaos. Although in macro reentry, the substrate can also change within the first 3 months. This blanking period. So this period, this first 3 months, is a therapy stabilization period or blanking period. It's referred to as such, during which this connective tissue is being healed. I was supposed to go out of the way to try and sustain sinus rhythm. One of the diamonds, one of the pearls during the ESC Congress of 2020, European Society of Cardiologists of 2020, was the publication of this trial with EAST-FNET4. For this reason, during the AFib trial that was carried out in 2004, the kind of a nickel sign was put between the rhythm control and frequency control. There didn't appear to be a difference in survival and even in the quality of life. However, many things in this world do change as technologies develop, as technologies progress. The EAST-FNET4 trial showed that in long term, these patients will benefit. Paulus Kirchhoff, who was the first author of 2016 guidelines, did that presentation. A huge trial, 2,800 patients from 135 centers in 11 countries they were randomized into early rhythm control, active rhythm control, using antiarrhythmics or ablation, and the other group was conventional care, routine rate control therapy, without active rhythm targeting, although there was some overlapping, so the strategies were not completely mutually exclusive. However, in the initial rhythm control group, initially 8% of patients were sent for ablation. By the end of year 2, there was almost 20% of patients. So 1/5 of the patients on antiarrhythmics was sent for ablation. In the conventional care group, 7% of patients had undergone atrial fibrillation ablation. You can see the drugs: propafenone, flecainide, amiodarone, dronedarone. They were used in the rhythm control group. And 8% of initial ablations, 19.4%, almost 20% by the end of year 2. In the other group, frequency control group, with no rhythm control efforts, still 7% of patients were sent for ablation at the end of year 2, or by the end of year 2. The trial was stopped at a median of 5 years of follow-up per patient, although some patients were followed up to 8 years. And it was proved that if a first primary endpoint event combined cardiovascular death, stroke, or hospitalization for either heart failure or acute coronary syndrome, so it's not a rhythm disruption, so heart failure, HF, or ACS. These are the parameters that actually affect survival. In the rhythm control group, there were only 3.9%, 3.9 cases per 100 person years, and 5 per 100 person years in the conventional care group. So 3.9 versus 5. So these curves did diverge around year 8 by around 20% relatively, by around 10%. And it showed that early rhythm control tends to benefit long-term, not just with respect to life quality, but also in terms of survival. And we go back to this cornerstone phrase, the founding phrase: AF begets AF. Cardioversion is one of the elements of rhythm control that helps maintain, helps sustain sinus rhythm, and helps prevent further progression of atrial fibrillation. What we do not know is position paper of 2019. These are the knowledge gaps in atrial fibrillation pathophysiology. We do not know the defining actionable patient-specific molecular arrhythmia mechanisms. We do not know key dynamic modulators. Unknown are the mechanism to target. So what's achieving atrial targeting a specific molecular arrhythmic mechanism with drugs? We do not know that. Specific molecular cellular AFib pathophysiology, we do not know that. So Albert Einstein quotes, "If you can't explain that to your grandma, then you don't understand it yourself." So most likely this is the status quo in terms of our understanding of AF these days, although empirically we help hundreds and thousands of patients. Thank you very much for your attention.
Спасибо большое, глубоко уважаемый
Thank you so
профессор.
much, esteemed Professor Puodziukynas.
Уважаемые коллеги, у кого есть вопросы?
Dear colleagues, who have questions to the presenter? I have one. Yes, please, Victor, go ahead. Possibly you'll be able to tell me what are the incidence per million of population of RFA, of atrial fibrillation? What is the statistics in Lithuania? So let me do the math. Per million, I'll just need to pull up a calculator. Per million population. So let me talk more figuratively. Per year, our clinics does 600 to 650 RFA a year. Of these, 7 to 8% are AFib related RFA. Global figures, world standards, most likely because more patients receive this kind of patients. There are clinics with RFA for AFib, 55 to 60% of all the mix, of all the ablations done by these institutions. So we're doing comparatively low numbers of AFib RFAs, but within the past 3 years, every year we have a 30% increase of these ablations for AFib patients. So that's your clinic alone. What about Vilnius? Yes, there is also a Vilnius clinic. It also does, give or take, the same number of ablations. There is a Klaipėda center, the third center. In March, they did the first cryoballoon ablations, mostly because of this pandemic times. And they've suspended this practice for a short while now. But looking at global practice, well, Philadelphia is a big city out there, but 16 electrophysiological labs, 16 per city. 2-year-old data, 2.8 million people in that metropolis area, 16 labs. It's a matter of demand. So the big question is how well we cover the demand in our country. Dearest colleagues, further questions, please, to Professor Puodziukynas. Are there any? Sergey? And we have Yuri joining us. Do you have questions to Professor Aras? No, I have none. You can hear me, right? Yes. This wonderful trial that you have just shown, the ESC 2020 Congress for Early Interventions in AFibs. What is the role of catheter ablation? This 20% after 2 years was subjected to catheter ablation. Sinus rhythm was attained 86% in the intervention group and 60% in the conventional care group. Is that because of the catheter ablation, or was there some other story behind that? I believe that same way as after any other trial. So over the past years, there have been many discussions and conversations about new and direct OACs, DOACs. So a headline or a flagship article is published that gives the bulk of the results, and then sub-analyses follow. So I mean that there will be sub-analyses after that paper because there is a huge sample of patients. So we will get more additional data from that paper. However, I still think that the role of catheter ablation is immense. The very fact itself of antiarrhythmics to sustain sinus rhythm, yeah, after Athena trial, we thought that, all right, well, people survive nonetheless, so why should we try harder? So yes, they still live on, but the life is not longer, and the quality of life suffers. So catheter ablation plus antiarrhythmics makes sense, is relevant. Thank you.
Спасибо большое. Aras Leonovich.
Thank you. Aras, may I throw in a question of my own? Yes, sure, by all means. Right, so this conventional thinking about cardioversion that our young colleagues receive at school, med school. Cardioversion, is that urgent assistance is that emergency care for patients with AFib that obviously have some hemodynamic compromise. In all the patients that HF progression, angina pectoris, we're not talking about extreme versions of, say, loss of consciousness, vertigo, hypotensions. So this traditional picture of cardioversion is instilled into the minds of young cardiologists, of GPs. What about our case? We are talking about this technology as not emergency but routine. And essentially we say, or we talk about cardioversion as a way to treat AFib. Would you agree that cardioversion from the section of urgent or emergency care practices should be strategically changed to routine care, to elective care, without any significant manifestation of hemodynamic component in patients too? And thirdly, whether this should be regarded as a curative event or curative intervention. AFib begets AFib, let me quote that. We can interpret that well, conversely. Sinus rhythm begets sinus rhythm. So how would you comment on that? Well, not necessarily. I fully agree that that's one of the ways to treat AFib patients. It should be part of our toolkit, both as emergency, but it should also be used electively, routinely. Because if God created a man and there will be a sinus rhythm in that person, in that man, so yeah, well, the sinus rhythm is there. So what is the price to pay for having the sinus rhythm? We're not just doing that with higher care or higher thoroughness. Sometimes there is excessive activity that we see. The rhythm is not restored, or there are some disruptions that follow for 10-15 seconds. 6, 7, 8 shocks. So we're supposed to change something. We should not be doing blindly same thing over and over again. So yes, making one mistake is more or less all right, rara humanum est. But if we do that same mistake over and over again, that's no good. So we're supposed to navigate people around the use of antiarrhythmic drugs after the cardioversion without repeating the cardioversion. So that's one of the ways to achieve sinus rhythm. This is one of the parts of the battle for sinus rhythm. Yuri, what about your position? Is it urgent or is it routine? What would you say? It's especially important for patients post-RFA. Well, even spontaneous sinus rhythm, catheter ablation, they're all ways to restore sinus rhythm. Well, that's kind of a addendum to electric cardioversion. Well, for 2 centuries, last century in the beginning of this, we are doing electric cardioversion for AFib. I think that electric cardioversion is more of an emergency procedure, especially, or at least at those centers where contemporary electrophysiological assistance is, cardiosurgery is available. I don't think it's a pleasure for patients to undergo this sedation, it's narcosis. We don't know how many cardiomyocytes are damaged in electric cardioversion. But what I think is a safe bet, it's not improving the patient's health. So we should minimize the number of electric cardioversions. It should be considered as a more of a radical approach to treatment. Sergey, what about you? What do you have to say? Well, I'm advocating the pharmacotherapy position. pharmacotherapy, drug therapy, is in many cases not inferior to electric cardioversion. I'm not going to advertise Ferigil, which was created in Moscow, which is a good benefit. Well, self-assistance, taking patients perorally to eliminate AFib, or patients can help themselves. Electric cardioversion is the case when pharmacodynamic or pharmacological might not help sufficiently, or some emergency situations, some urgent situations. There are some regional preferences to that or another manner of cardioversion, but if the drug assisted is not efficient electric, unstable hemodynamics, definitely electric cardioversion. So typically this is the case. This is my opinion. Thank you. Completing our discussion for this topic, let me assure you, dear colleagues, that cardioversion for us has been an important measure for many years now in the comprehensive treatment of patients that underwent AFib. In early period or blanking period, no matter what label you slap on it, it's a very important period. It's a very important point. Sinus rhythm begets sinus rhythm. It is relevant, it works. The more exposure in early time frame, the better. The higher chances we will have to get good effects, good prolonged outcomes for our patients post-procedurally. It is my huge interest and pleasure to announce the presentation by Yjuri Karpenko, Odessa, Ukraine. He'll be talking about the repeated RFA procedures in AFib patients. This is really a burning problem for all the OR people in our teams. So he'll be talking about re-ablation. Whom, when, in what amount, in what volume? Yes, thank you, Andrey, because I was pleased myself to prepare for this presentation. I didn't know quite a lot myself. So many positions, so many outlooks on this issue. So how do I start? Yes, next slide. Okay. My personal experience over the past decade is 3,000 catheter ablations for AFib. So how am I supposed to look? How am I supposed to feel when I'm thinking about a re-procedure, a re-ablation? I think the right-hand picture is my feel today when I'm doing a re-ablation, not the left-hand side one. I am worried myself because I don't really know, although it's really amazing. We are looking at pre-op charts, we are looking post-op charts, MRI, CT, quality imaging, TEE, echocardio, so history analysis. But still, we're at the crossroads, we're in the maze because we don't know what kind of an outcome the next ablation will bring about. Aras has already shown this anatomic structure. There's convoluted muscles around pulmonary veins, but yet the surgeons were the first ones that did not know the actual, well, divide et impera principle, divide and rule. So this is the distal right atrium, then the appendage, LA appendage. Some surgeons do lines in the right atrium. This was the surgical ablation, Jimmy Cox. 99% of cases, AF was eliminated, and only 2% of patients were on AADs. 178 patients after MACE CP, the cardiac rhythm after MACE surgery was preserved for 10 years in 93% of cases. Well, these are the figures that we're dreaming about, but the re-ablations are still a fact. No matter how hard we try, the atriopathy is going to progress, because the atrium pathology itself is causing bad things to happen. The progression of hypertension, heart defects, old age. So this is going to worsen the patient's condition as time goes on. So no matter how hard we try, we're going to try and change the change the substrate. We're going to find for every % of life quality parameters. This Cabana trial, could be interpreted different ways. So some say that there was no benefit, and some say there was benefit for symptom relapses or symptomatic recurrences. But still, the catheter ablation causes AF recurrences and symptomatic recurrences to come down, to go down by half over the 5 years. So a recurrence is different from another recurrence sometimes. If a patient feels nothing and the quality of life is improved, or the ablation outcome is good. So 30 seconds in any atrial arrhythmia is a very tough threshold. Revascularization of myocardium. 30 seconds is the cabbage CABG, so grafting. Is it going to be a success or not in 30 seconds? Well, everybody here in atrial fibrillation talk about this 30 seconds more or less, or under or over 30 seconds. This is an important factor. Another important point from the point of the disease is the atrial fibrillation burden. In this case, ablation is much better in terms of a lower burden. The patients do not feel AFib. Ischemic strokes definitely are reduced. That maze approach, the paroxysmal form, we know that these triggers are in the ostia of the pulmonary veins. Maybe they should be re-isolated. Surgically, it's simple. In persistent forms, it could be rotary. How to get to those rotors, we don't know how to get it done. Typically, there were 2 or 3 rotors, and they were not always anatomically fixed. They could shift as time went by. There is Marshall vein, the ligament of Marshall, left and right pulmonary veins, superior, inferior. So there is a very convoluted chart on the right-hand side below. So this is not really a maze. It's even worse than that. We do not even know our way around or out of it today. Re-isolation of pulmonary veins in paroxysmal AF. That's possibly what we should target first of all. Additional lines are criticized today, receiving some criticism, although in some cases there is a reason to do that line, to do those lines. This one, our data shows it doesn't make sense. The D side, the D part, defragmenting the distal, the distal wall could bring results. 5-year-old trial, Verma et al. We see the pulmonary vein isolation plus electrograms, and isolation plus lines. That was featured in the first presentation of the day. 59% PV isolation only, isolation plus CFAE 49%, isolation plus line 46%. If we're looking at the charts, the layout of these lesions, there was a big contrary isolation. Almost the entire roof of the left atrium was affected, plus the ostia of pulmonary veins. Fragmentary activity. So we do it like this. This is the chart. This is the roof line. No particular difference between methodologies 1, 2, and 3, except for this mitral line that electrophysiologists know is very tough to pull off, especially in patients with paramitral flutter. So let's talk about catheter maze going back to 1994. Hesseger did the first attempt to separate the right atrium, because it was believed at the time that these mechanisms are focused in the right atrium. So we're trying to forget that now. This is the isolation of pulmonary vein, circular isolation from our lab. This is the golden standard, circular isolation of PVs. There's no signal conductivity in these pulmonary veins. Most likely, this patient will be recurrence-free. However, the price to pay for the repeated surgeries, you see the stenosis of PVs. That's one of the failed cases. Reprocedure caused this dramatic stenosis. Highly symptomatic patient. We had to do stenting of this PVs. So there was a major issue in that. Repeated isolation should be as far as possible from that. So staying far away from ostia of PVs. However, these failed procedures, they still manifest. So the trials that we've been looking at, there was a trial that was published 4 years ago. This is not a rare situation. 20 to 40% of recurrence post-ablation. Well, that's quite a lot. The number of these patients sent for repeated ablation, that number differs clinics by clinics, the different policies. And yet, the patients that are sent for repeated procedure, they should be atraumatic. So what do we want to get with that reablation? Extending patient's life, less likely. Symptoms, well, symptomatically, if there are no contraindications, the patients should be sent for reablation to treat symptoms. Versatile strategies of repeated ablations like linear substrate modification, there's no significant proof. But apart for reablations, concomitant conditions and states should be treated. Arterial hypertension, obesity, sleep disorders that increase the risk of atrial fibrillation, they should be managed as well. Plus, we should be looking at pulmonary veins, electric mapping, additional strategies such as distal wall isolation, atrial, left atrium distal wall is isolation, the atrial roof, vena cava, superior. Could be coronary sinus, could be left atrial appendage, intra-atrial septum, inferior vena cava, superior vena cava. So yeah, there are some strategies that can improve the outcomes of this repeated ablation. Quite unexpected for me was the general anesthesia. It reduces the number. System anesthesia in reablations reduces the number of recurrences compared to deep sedation, 19 versus 42%. Respiratory excursion reduction, stabilization of ablation, catheter guided introducers, multi-pore, cooling or coolable electrode, contact force catheters, they should also be used for reablations as well. These are the ways to reinforce or to boost the efficiency of catheter ablation in our patients. Tests to assess the block of entry and exit into the left ventricle after 30 minutes following the acute pulmonary vein isolation improves the long-term results. Adenosine is doubted by many authors, adenosine administration. The rational approach to reprocedures is this. First question to ask, PVs, are they isolated or not? If no, then they should be re-isolated and the blocks of entry-exit should be confirmed. If they are indeed isolated, we should look for triggers exterior to or external to pulmonary veins. If we find those triggers, then yes, we should ablate the triggers outside the PVs. If no, we need to induce atrial flutter. If there is induction, then we'll go for ablation of atrial flutter. well, doing that, inducing that flutter and ablating it, it's quite difficult procedure. Plus some anatomic catheter ablation outside the pulmonary veins, some activity zones. Cryoablation is also a rational approach that can look like this. It's a very elegant work. 40 patients with atrial fibrillation recurrence post-cryo. 25% had unisolated PVs after the first procedure. If the balloon, a 23 millimeter balloon was used, then a bigger balloon was used in a redo procedure to get a more antral, more massive isolation, and vice versa. If a 28 millimeter balloon was used before, then a smaller diameter balloon is used later on to get a deeper ablation. 70% of reprocedures without recurrences, 70% within 12 months were recurrence-free. This is an interesting methodology that I like because of the logic behind it. This is how PV isolation works. We see the coronary sinus is in sinus rhythm, but within some pulmonary vein, in this case it's right superior pulmonary vein, there is a gap. So what do we do with this residual? Well, we need to try to do it from within the pulmonary veins to eliminate this AFib from within the pulmonary veins. Definitely good mapping systems, high density mapping systems enable us identifying these possible penetration zones or possible permeability zones in the PVs. So the reablation should be done or should be targeting those sites primarily. Those methods exist today. This is a work I like by Brazilian authors, quite interesting in their approach, quite original. They've looked at the data of 8 observational studies, 700 patients, PV isolation, follow-up 3 to 12 months, with MRI with gadolinium. The higher the damage with cryoablation, the fewer, the higher the damage of CRAs, the less recurrences, the fewer recurrences of atrial fibrillation. But the price to pay for this additional ablation is a stiff atrium, stunning of the atrium, also damage to the esophagus, hemopericardium. Nonetheless, we understand that no damage means no result. So ablations should be massive. They should be more antral. They should not be targeting isolation of PVs as well. They should also be modifying the substrate. This was proven by the previous slides. A couple of words about those ERAFs, which are not tolerated well by the patients. It's first days post-ablation. Mostly it's not even atrial fibrillation. That's flutter, high-frequency flutter. That is very tiring for patients. Unfortunately, well, there's no way around that. 2 or 3 months of blanking period should be survived, should be suffered through, so that after 3 months we can think about re-ablation or not. So this could be right atrium flutter. This could be other types of flutter, inflammatory cascade, modification of autonomous nervous system, substrate modification. We try to go for beta blockers. First cardioversion is only done after 2 or 3 weeks, once that acute stage inflammatory response is reduced. The markers, even the exudate is seen on echo. So this is very easy to monitor and to handle. ERAFs in the blanking period. Well, there are some clinical characteristics. They can be very early, within several days or within several months, up to 3 months. That's early recurrences, ERAFs. Most likely in hospital, these are older patients in non-paroxysmal forms. Electrophysiological predictors of recurrences is incomplete isolation of PVs, although I don't think that many electrophysiologists today will complete the procedure without checking that. Incomplete isolation, okay. Inducibility of AF, if it's inducible, what do we do next? AFibs are not fixed in catheter ablation. Non-anatomic strategy is vessel lines, KFs, plexi, imagery, well, left atrium, the blown up, size, volume, fibrosis. These are the markers for further issues. The quintessence of the things we've discussed before, there are early recurrences, structural heart disease, and so on and so forth, late recurrences and very late recurrences. Very late are 3 years after the procedure. That's not even recurrences per se. That's most likely the progression of the disease, because 3 years on, that's quite a lot of time down the line. So what is good and what is bad in reablations? Because what needs to be done, we don't know that full well. What should not be done, we have guidelines for that. Well, stimulation and mapping, we should go for full continuity of lines. Additional ablations, well, the use of these ablations has not been proved. Possibly one case, a macro reentry atrial flutter, that cause additional linear ablations. If we find this focal trigger outside the PVs, it makes sense to search for that trigger outside these pulmonary veins. This is the only proven situation. But again, nobody knows how to look for those triggers. Distal wall isolation can be considered in primary and repeated procedures, but it's only 2B, class and grade. Same goes 2B goes for the ablation of zones of fractionated high-frequency signals, KFI. So even some doctorates were defended based on that, but it was proven that it is not proven. It was found that it's not actually proven. Non-ablation strategies of improvement of catheter ablation. The body weight reduction before and after the surgery. How do we control atrial hypertension? Well, that's useful, but not always clear. Sleep apnea, we know that there is a link with atrial fibrillation. However, this sleep apnea or hypopnea did not cause the AFibs to go down. That's another work I liked a lot. So it shows that we have inadequate knowledge. And essentially, after ablation, before the ablation. Tough control. Some were controlled in a tough manner, well, 120 by 80. Others were featuring a higher threshold, 140 by 90. The follow-up median was 14 months. The tight control group, there was a better outcomes, but the recurrences of AFib were the same, roughly the same, 61.4 and 61.2. In patients with severe or stringent blood pressure control, there was a life quality reduction because of hypotension attacks or episodes. Everybody wants to compare RF and cryoballoon, CB and RF, with respect to recurrences. There's no recurrence difference. There's no statistical difference. But ERAFs were lower in catheter ablation group. Mostly it's because of the damage mechanism. Less local inflammatory response. Because of the zone that is ablated in these patients. So theoretically, catheter ablation brings a better outcome, brings a benefit in terms of lower count of ERAFs. Reablation in patients with chronic and persistent AF forms. What should be done in that? Well, I've been looking at the guidelines and found this. 1/4 of experts, 22% of the working group, they do the distal wall ablation, isolation, in primary, and 38% up to 38% in redos. What are the catheter ablation efficient criteria for persistent AFib? Well, electric isolation of PV, that's a must. Most likely it's there. If not, then several applications and we'll get it done. We dream to remove AFib at the backdrop of ablation, although it's and restore the sinus rhythm, although it's a predictor of long-term effect. We also like the AFib to transform into some regular tachycardia or atrial flutter. The longer the cycle, the more joyful we are, because we know that we're closer to the goal, restoring the sinus rhythm. The AFib cycle is slowed down. It's another criterion. So our standard methodology is pulmonary vein isolation, roofing, plus this plus the neck, the frontal and mitral neck. We do it. Isolation of pulmonary veins, distal wall, coronary sinus isolation in the left atrium. So this is a very bright picture of these veins. It's a complicated methodology. There is a increased risk. Well, the distal wall works. We are practically sure that this is the cornerstone. Well, this is very important. Both on the endocardium and pericardium side, we should do this isolation. A Marshall ligament to get re-isolation done. So it's quite complicated. Literally last week we did this patient, a massive ablation in the left atrium. Even before the ablation was done, almost the entire atrium was gray. That's the voltage map, less than 0.5 volts. And only LA appendage and the mitral neck shows this. Well, mitral isthmus gives us this signal, higher signal. The PVs were isolated here, left, right, roof, and atrial septum. Same low amplitude. Mitral isthmus, distal wall, LA appendage. When we did this, the first procedure was complete maze, but now the sinus rhythm has been restored, SR. The protocol envisages the induction of atrial fibrillation, but we didn't. It was atypical of atrial flutter. And we saw that the stimulation of atrial appendage gives this interval, which is basically atrial tachycardia, indicative of atrial tachycardia. This was the mapping that we've done, a good forerunning zone, although we did not see a channel here. So these are the transitions that we've seen, we've established. We're very happy with these results, with the outcomes of this patient. LRAFs, that's a big group of patients that was studied. Out of 10,000 of atrial fibrillation ablations, at least one PV reconnection was seen in 81% of cases. 111 of 137 recurring cases. PV re-isolation with antral extension of ablation sets, posterior wall ablation, SVC ablation, septal to right PVs, well, roof line, cavo-tricuspid isthmus line. These were the strategies for repeated ablation. Although still the arrhythmia-free patients dominated, three-fourths after these repeated. so many methodologies that were targeting substrate modification. Another big issue is this atrial tachycardia that occur after PVIs. They are more severe than the atrial fibrillation that was treated. They manifest more severely. There are several kinds: trigger, focal, macro reentry that covers a huge segment of the left atrium, and these channeled ones, micro reentry. Atrial tachycardia is a big percentage of these complications. We need to look for this tachycardia, earliest activation site for ablation target. We do that for triggered activity and localized reentry. The critical neck or isthmus is identified, the conduction isthmus. Same for macro reentry. This is the case from the previous week. A patient after a massive first procedure, there was a second repeated one. This is the distal wall of the atrium. We designed, or we mapped this voltage picture for more than an hour. When we stimulated the right atrium, there was a very huge interval. There was a huge interval. Spacing interval, cross spacing interval was 318 milliseconds. We restored the sinus rhythm, so it took a long time to build the map, to do the mapping, but a very quick procedure to fix that patient, to help that patient. The Austin group, they are targeting the left atrial appendage. In a number of cases, they achieve electrical isolation. These appendages are quite tough structure, up to 6 millimeter thick walls. The isthmus is very tough to reach. Yes, it does improve the situation. It does reduce the number of recurrences. The sinus rhythm is restored, but there's a fourfold increase of strokes, even on anticoagulants. Because even on sinus rhythm, the anticoagulants will not prevent clotting from embolic complications. Even the authors themselves claim this methodology to be wrong. The entire world is looking for substrate for ablation, the entire medical community. If the number of fibrosis is this small, UTA class 1, UTA grade 1, ablation will work, antiarrhythmics will work, and vice versa. If it's 50 to 60% of fibrotic tissue in the left atrium, not one strategy will work. Not antiarrhythmics will work because there's simply no action site for them, not a procedure. So these are different patients, of course. This is what the progression of disease might look like. Cardiomyocytes die quite quickly. So histology can develop from this to this in a matter of months. Almost all cardiomyocytes will be replaced by fibrotic tissue. Stage 4, you can see the curve right there. Up to 50% recurrence within the first year of life. The correlation of these recurrences is related to fibrosis, not some clinical issues. Severe heart failure, CHF, is not even worsening the prognosis of these patients. Stage 4 of SRM does. A group of authors were looking at patients with ejection fraction less than 35%. And these were the patients that were targeted for ablation. Fibrosis is one of the failure predictors. Why does fibrosis build up in the distal wall? So this is the posterior wall segment. We see that when atria and ventricles contract, these are the sites that are distended the most. Hence, more fibrosis. So this posterior wall studies show us that almost all pulmonary veins get damaged. The appendage of the left atrium is intact. We almost never observe fibrosis there. Fibrosis is manifested in the areas that are most distended during the contraction expansion stages. stretch, inflammation, fibrosis, fibrillation. That's the path. That's the path. The posterior wall itself has some prerequisites for further fibrosis development. So posterior and anterior wall. So in humans, of course, this is the picture. In animals, it's very different. But in left atrium, posterior wall, these are the typical fibrosis sites. I'm excluding all other diseases. It's just fibrosis. There is a very strong correlation between MRI, color MRI, gadolinium. There are some techniques that will try to isolate BIFA, box isolation of fibrotic areas. There will be tactics like or strategies like that emerging to help the clinicians. In this case, the anterior wall, we see the recirculation, the isolation. The signal is gone in this wall. These are the good candidates for this methodology, for BIFA. Totally low amplitude activity, completely red, left atrium, like a strawberry picture. There's no methodologies to isolate these segments because the entire left atrium is fibrotic. The MRI itself, there is a assessment of the function, assessment of the structure, various segments of the left atrium. Normally they contract simultaneously. If this sync is off by more than 2.86%, we see a very big difference in increased recurrences. So the more fibrosis there is, if the pulse is not progressing properly across the atrium, the worse off the patients are going to be. So, this is the SOTPS, SD, standard deviation for these patients, the more sensitive criteria. There are ultrasound systems, quite sophisticated ones, that can tell us whether the left atrium is okay or not. And there is desynchronized, one of our most recent pictures. We did this patient today. So globally strain is around 20%. This is the atrial roof contraction, very good contractility. And in this case, dyskinesia in this roof segment. This patient is somewhat fibrotic. The global function is okay, but there are local fibrotic lesions. So this is dessert for you. This is the map for the best candidates for reablations, catheter reablation, CRAs. A good candidate, a bad candidate, and suboptimal. Young, paroxysmal, linear sizes, 4.5 centimeters, 30 milliliters by square meter. Index, reservoir strain, 30%. The average candidates and suboptimal are column 2 and 3 respectively. We also study biochemistry, serum NT-proBNP. The higher it is, the worse off the prognosis is. The worse off the patient is going to be, the worse the prognosis is. If there are no other options, ablation cannot restore the sinus rhythm. We can destroy the AV node. This is what we do. Plus the His bundle. We implant the electrode right into the His bundle, and this is what we get. A very normal cardiogram. We control the contractility and we get a very good geometry of left and right ventricular contractility. So this patient is going to be doing fine. Thank you very much indeed for your attention.
Okay. Меня слышно, да?
Can you hear me?
Ромчик.
Извините, а вы будете сейчас продолжать, да, или что?
Are you going to continue now? No, I'm done. Thanks for your attention. I'm done with my slides.
Спасибо большое, глубоко уважаемый Юрий Иванович.
Thank you very much indeed, esteemed Yuri, for your amazing presentation. Unfortunately, the time is running short. Maybe one small question is permitted. And I would like to give that opportunity to non-surgeons, people who are taking part in our today's conference. One short question is allowed, please. Sergey, are you with us? Do you have a question to renowned surgeon? You as a therapist, GP. Well, I'm amazed by what I've heard and what I've seen. It's just a brief comment that I can share. No questions. If I could, I would have hugged Professor Karpenko for this amazing work that he's been doing. Thank you. Thank you for this. Viktor, you might have a question.
Нет, вопросов нет.
Ирина Вячеславовна.
No questions there. A very interesting report. Irina? None. Aras? Yes, I have a really quick question. Is there a patient whom you say no for a redo? What kind of patients are refused? Yes, unfortunately, the majority of patients are a no-go because we're looking at the anomalies in left atrium, anatomic ones, electrophysiological ones. We realize that there's no way a redo can help. If we cannot control the symptoms, first of all, the heart rate, then we go for plan B. So we're looking at this with brand new eyes, the destruction of AV node. We will not improve the patient's situation because we restore the frequency control, the rate, heart rate, and the left bundle, the left leg of the bundle. Well, it's a big problem. Well, thank you very much, dear colleagues. Should the time permit, should there be a wish or desire to chat in today's conference in Zoom, well, this is more than welcome. I believe the presenters will take your questions happily. So a very comprehensive presentation. Thank you very much, like everyone that was before. Thank you. Now I'd like to give the floor to the next speaker. He is the fellow of the National Academy of Sciences of the Republic of Belarus, rector of the Grodno State Medical University, Viktor Snezhitsky. He'll be talking about atrial fibrillation and sudden cardiac death. So what we're trying to prevent with those aggressive tactics that we engage. Sudden cardiac death particularly. So this is the topic of today's Viktor's presentation.
Позвольте вам представить
Презентацию во весь экран, пожалуйста.
Я извиняюсь, надо на начало, да.
So let me go to the first slides of my presentation. Now, talking about atrial fibrillation and the indicators or predictors of mortality in this type of arrhythmia, in patients with this arrhythmia type, then we need to single out all-cause mortality, sudden cardiac death, cardiovascular mortality, because in the vast amount of cases, this mechanism is going to manifest in our patients. In atrial fibrillation in general, we're looking at a whole range of conditions that are associated with unfavorable outcome. Mortality, strokes, hospitalization, quality of life reduction, systolic dysfunction, local cardiomyopathy, as well as cognitive disorders and vascular dementia, which are also very significant. Statistical data for these directions are abundant. They show the relevance of each one of these directions of areas of science. Definitely, a GP or cardiologist should clearly know all these components. The most important ones are the first two. all in all, the prevalence of AF in the global population is quite high. We have tens of millions of people who suffer from that condition. That's roughly 3% of adults 20 years plus. The maximum prevalence is in senior patients. This is known based on the Framingham study. Atrial fibrillation is associated with a twofold all-cause mortality increase in women and 1.5-fold increase in males. Looking at some meta-analyses that are dedicated to this pathology, and a few come to mind. 2017 meta-analysis of the association of atrial fibrillation and sudden cardiac death. They have shown out of 27 trials from 1997 to 2017, 8,400 patients were included with atrial fibrillation and 67,000 AF-free patients. For the first time, it was shown that the patients with AF had a significantly higher risk of sudden cardiac death. It was the risk ratio was 204. Subgroups of patients with IHD, myocardial infarction, heart failure, some kind of cardiomyopathies, Brugade syndrome, implanted devices, they had an elevated risk of sudden cardiac death. Engage AF-TME also showed that in the sudden cardiac death structure, it was quite high. It was 4.2%. Average age is around 73 years, mostly males. In patients with AF, this is an important prognostic factor. 93% are outside the hospital, 66% without any forerunning symptoms that could point at sudden cardiac death probability. The outcomes of this trial showed that the low ejection fraction, congestive heart failure or chronic heart failure, MI were the predictors. Additional risk factors were male gender, male sex, high heart rate, issues with the left ventricle, as well as non-use of beta adrenal blockers and the intake of digoxin. This is very important because the routine practice allows the studies of various empirical findings across various centers. Talking about some national registers, we also see that the overall mortality among patients, hospitalized patients, Swedish registry data, AF is an independent risk factor of all-cause mortality. Compared to other comorbidities, AF is the main contributor, is the highest contributor towards all-cause mortality indicator. So its contribution, its negative contribution is significant. The differences in sexes is also very important, according to the Swedish registry. So women tend to suffer more, or tend to die more frequently compared to males or younger patients, regardless of the sex. Epidemiology, on top of antiarrhythmic drugs and catheter ablation, we associate the success of our therapy with adequate anticoagulation therapy. Based on contemporary trials, the incidence of the strokes is around 1.5% a year. At the same time, the annual mortality ratio is around 3% at the background of continuous anticoagulation therapy. Lethality post-stroke or mortality after stroke can be reduced with anticoagulation. there are some anticoagulants that we can use to stabilize and improve the benefits of the treatment. To a lesser extent, mortality can be associated with a stroke. At the same time, sudden cardiac death or progressing heart failure induced death are more frequent reasons for patients dying. In this case, interventions should be considered more actively. Drugs, beta-adrenal blockers, drug therapy, beta-adrenal blockers, how can it benefit? This is the question that I wanted to ask to Professor Kanorsky, was the use of beta-adrenal blockers. We've talked about amiodarone, propafenone, but we failed to mention the beta-adrenal blockers, beta blockers. Oftentimes, patients benefit from that because AF significantly increases the risk of cardiac death in patients with chronic heart failure. We should also be thinking about recurrences of AF post-ablation. In this case, combined therapy should be considered. And again, what should we combine with what? There is a lack of evidence in these. Propafenone in one case, amiodarone in other cases, amiodarone plus beta blockers for ventricular disorders, for tougher situations. Why is cardiac death quite frequent in this category of patients? Because of ventricular arrhythmias. So this is what further upcoming trials should give us the answer to. This is an old study of 2005. It was shown that carvedilol improved the prognosis of patients with chronic heart failure. If during follow-up patients with existing heart failure, atrial fibrillation appeared later, then this patient category did not benefit from this treatment. Beta blockers for patients with sinus rhythm, all-cause mortality, sinus rhythm and AF. You see the divergence of the curves, placebo versus beta blocker of this 2015 trial, 5-year-old trial. So beta blockers are more efficient in patients with sinus rhythm and less efficient, statistically insignificant in patients with atrial fibrillation. Beta blockers do not help these. Digoxin. A number of trials have shown that it worsened the prognosis of patients that were taking it. When it was prescribed to treat for heart failure or to control the heart rate, well, the risk could go up as high as 27%, the risk of all-cause mortality, and 21% increase in cardiovascular mortality. Patients with AF without heart failure had a high risk of all-cause mortality compared to patients with heart failure. Odds ratio of 1.47. A firm trial that was published back in 2008 show that we should gear towards sinus rhythm restoration. We should go for that. Sinus rhythm reduces the mortality figures by 46%. Digoxin or antiarrhythmics increase it by 50 and 41% respectively. This is yet another confirmation to the points I've made before. Indeed, warfarin anticoagulants are reducing the risk by 53% in that trial. Warfarin was anticoagulant used in that trial. What is the actual practice in Europe? Who do we prescribe? RFA. Who suffers from recurrences? This is the EURP AF trial, 2-year follow-up. 5% mortality among patients with AFib. Cardiovascular issues, cardiovascular causes of mortality, 62%. So again, this 5% figure above is quite a lot. 5% of people dying over 2 years of follow-up. It's quite a lot. So CV causes, I mentioned, it's 2/3, almost 2/3, 62%. Any cardiovascular hospitalization cause for a patient with AF means a worse prognosis. Looking at the Japanese patients' mortality, particularly in Japan, so other world regions, particularly Japan, the structure of these causes is strongly dependent on the age. Younger patients under 64, under 74, the malignancies tend to dominate. Cardiac issues, only 16%. 85 plus patients, the higher percentage is infectious states that can cause lethal outcomes. So the range of issues is quite broad, depending on the region in the world, depending on the age of the patients. The cause of cardiac related issues, hemorrhages, is within 20% either way. Intracranial, particularly gastric. German-wide Helios Hospital Network data of 2010-2017 shows the intra-hospital mortality of 0.6%, which is quite low. Although, given the number of patients, is quite indicative statistically. Hospitalization of people with AFibs meaningfully reduces the mortality risk. Multi-factor or multivariant analysis shows the impact of patient age, OR 269, the capacity of the hospital, 0.57, and the emergency services rendered by the hospital, 157. Charlson comorbidity index, 495, very high. Lethality post or peri-ablative was 0.05%, 0.3 for atrial fibrillation in the right atrium, and 0.56 when occluders are implanted into the LA appendage. According to the British data, this is the UK Biobank cohort, 500,000 plus patients aged 37 to 73. They were enrolled in 2006 through 2010. Follow-up 7 years, 0.7% were patients with AF, mean age 62. This work also showed the comorbidity 4 and more comorbidities are a significant 6-fold increase of death risk. The stroke was not the most important factor, no matter how surprising it might be. The comorbidities was COPD and osteoporosis. Well, possibly fractures, pulmonary insufficiency, or respiratory failure. These are the main causes of death, not the stroke in the UK study. These are the patients with AFib that were on OX in various countries, various populations. For anticoagulants today, many experts point out that anticoagulants are very important. This is the cornerstone in therapy of patients with AF. But the further reserves are quite limited. We're quite constrained in our opportunities. All-cause mortality, vascular or cardiac mortality, further reduction of mortality because of anticoagulants, well, it's a very modest effect. We need to look for other novel strategies to target these patients. In this respect, we should look at a whole number of indicators: treatment of cardiac failure, prevention of sudden death, and the treatment of cardiac rhythm disorders. Of course, it's important, and I will talk about that later on, the sinus rhythm correction. This is the Swedish trial, 6,000 plus patients with AF and stroke. 3,000 were hospitalized with intracranial hemorrhages, and patients with severe gastrointestinal bleedings, 4,300 patients. So 90-day mortality was 25% after ischemic stroke, 32 post intracranial hemorrhages, and 16 post GI bleeds. Anticoagulants are important. Patients on warfarin compared to direct OX had a higher risk death. Adjusted hazard ratio was 136% after hemorrhages. The things we already know, this was published, this has been published for a long time, was being published. Patients with intracranial bleedings and GI bleedings that were receiving anti-platelet treatment, they were doing better. So actual European practice, going back to that, in 2 years there will be a new trial who the catheter ablation will benefit in Europe. These are younger patients, patients with fewer comorbidities, more symptomatic patients at the same time nonetheless, mostly paroxysmal AFs than persistent forms, lower stroke risk, lower risk of bleedings, predominantly males. These are the typical patients for CA in Europe. The data of 2019. These are the easier category of patients in terms of mortality, risk reduction. Patients with cardiac structural pathologies, with heart failure, older patients, comorbid patients, they are, of course, tougher to treat. Other trials are also showing the results, or are showing at the possible causes of that. Is assessment or under-assessment of inducible cardiomyopathy. This cardiomyopathy can contribute to higher fibrosis lesions in both ventricles and atria. Catheter ablation is improving the left ventricle function to a better state than heart rate control therapy. This is all to do with the cardiomyocytes function with inflammation, but still the successful catheter ablation can contribute more significantly to preserving the sinus rhythm, thereby removing the tachysystole out of the picture. Camera MRI clearly showed that the CA will be more efficient in patients, both in respect with prevention of cardiomyopathy, where myocardial fibrosis is less pronounced or absent. Super responders are the patients with no myocardial fibrosis. So, of course, if there is a larger trial underway, or when a larger trial has been completed, there could be a question about the paradigm shift to try and control the heart rate more than anything else. It's a predictive factor for success of catheter ablation. CASTLE-AF study, it's low count of patients, but 33 centers in 3 regions of the world. 387 patients with paroxysmal persistent AF, chronic heart failure, class 2 through 4, and preserved LVEF, rhythm control, heart rate control with amiodarone in 30% of patients out of the drug arm, of the pharmaceutical arm of the trial. These are the outcomes of the trial. The sinus rhythm was registered statistically significant, 3 times more significant, 3 times more frequently was attained in the group of catheter ablation with fewer recurrences. Primary endpoint, hospitalization or death, only occurred in 28% and 29% in the catheter ablation group and in 44% in the pharmaceutical therapy group alone, pharmaceutical group. Other positive effects, such as increased LVEF, were also seen in the catheter ablation group. Meta-analysis of 6 RCTs, some I've already mentioned, some not, a number of important trials. They have been meta-analyzed to show that these therapeutic strategies are different. Catheter ablation in a selective group of patients, sample of patients, improved LVEF, improved life quality of patients with AF and CHF, improved hospitalization rates, and all-cause mortality. All-cause mortality was also lower. Only 0.46 was the odds ratio. These 6 RCTs data showed that the freedom of episodes of AF was lower in the catheter ablation group. OR 24.2. That's an impressive result. That's another meta-analysis, quite recent one, only 2 years old. It helped us conclude that catheter ablation compared to pharmaceutical therapy causes the reduction of mortality, fewer recurrences of AF, improves LVEF, functional therapy, life quality compared to drugs. So a group of authors ran this important meta-analysis in 2018. We see that both mortality went down and the recurrences of AF are also down. All this allows us to reconsider our strategy today with respect to catheter ablation application. Today we know, or today we see that a number of patients that are not really severe but more symptomatic, younger patients with a higher count of comorbidities, that's important. So these should be benefiting from the catheter ablation in the first place. Okay, but we are interested in a tougher group of patients that we can also do the heart rate control with systolic dysfunction of left ventricle, with low ejection fraction, where sinus rhythm is particularly important, and not just reaching it, but also sustaining it, maintaining it. A number of trials that I've mentioned before have demonstrated that the biggest beneficial effect from the use of drug therapy can be achieved specifically in this tougher cohort of patients. This chart, published in the European Heart Journal in 2019, shows that if we have a patient with AF and heart failure, and there is an impaired ejection fraction, cardiomyopathy is not linked to other causes, but most likely it's a tachy-induced cardiomyopathy, then this patient is supposed to benefit from catheter ablation. They refer to this procedure. Other factors, well, they should be fixed prior to catheter ablation, of course. Patients with preserved ejection fraction, we see there are 2 options: catheter ablation intervention strategy and drug therapy, amiodarone. Other comorbidities and contraindications against catheter ablation can again bring the patients to pharmaceutical therapy. The risk-benefit, patient choice should be guided, the guiding points in this selection. First or second procedure, it's also important to know that and to take that into account. And the indication for pacemaker, implanted ICDs, CRTs, Well, that also they should also be considered. In all cases, we will have the beneficial effect if we do it right. The world is now discussing the necessity of a paradigm shift in patients with atrial fibrillation in favor of rhythm control, heart rate control. If there is a tachy-induced systolic dysfunction of left ventricle at the backdrop of atrial fibrillation is developing, we can try and go for catheter ablation. Antiarrhythmics should be expanded. We should avoid using the drugs that can increase the mortality risk. So 1C, antiarrhythmics and digoxin. So this approach should be stringent. We should not use the drugs that cause higher mortality risk. Direct OX should be used in patients with AF, and comorbidities should be targeted and treated. Thank you very much for your attention. Andrey, back to you. Thank you very much. Thank you very much, esteemed Viktor. All of us understand that the fact that the sinus rhythm improves the patient's well-being is empirically obvious to us as clinicians. We've seen that firsthand, each and every one of us. But the fact that there are proven statements, there are proven points that suggest that effective control of atrial fibrillation with RFA contribute to better survival curves, less probability of sudden cardiac death. That's of course impressive. I encourage all the participants of our today's webinar to join into the discussion of the presentation that has just been voiced by Viktor. So please, dear colleagues, who would like to take the floor? Yuri, your take. Yes, amazing presentation by cardiologist, arrhythmologist. If everyone listened to it and everyone heard it and acted on it, same as Viktor suggested, we would all have helped our patients. The dramatic situation that we have right now with this COVID, there was a time when all the patients were suffering without transportation. I've seen how quickly the compensation of patients with disrupted rhythm occurs. Atrial flutter, other bad things, other bad phenomena. I've seen that develop in a matter of days. So prompt intervention for prompt intervention techniques, CRT or catheter ablation. Again, there are questions about actual cardiopathy and concomitant atrial fibrillation patients. How do we distinguish those? So this is still an open question. Thank you very much for your presentation, Viktor. Yes, thank you, Yuri. Dear colleagues, I would like to point out your attention to this statement that many presenters have brought up, fibrotic changes. And if I may, I would like to ask those who deal with that. Aras manifested fibrotic changes, fibrotic lesions when you're mapping. For example, if on CODCAMP, it will be stage 3, advanced cardiomyopathy. Will you refuse or will you reject catheter ablation treatment? That's one. Secondly, are you going to reduce the extent or the scope of intervention? And you will be linking your interventions to the already existing fibrosis, trying to build on it or trying to be guided by it. And thirdly, the repeated intervention. would you have done it the same way as the novo patient? Is my question clear? What's the strategy? Yes, the question is clear. It's quite extensive. In this respect, regardless of the fact that I've asked it to Yuri, this provoking question was asked. If there is no patient like that, we do not say no to anyone. We explain and spend quite a lot of time at that, doing that. There are no patients that should not be benefiting or should not be sent for catheter ablation. The risk increases and the failure risk might also be high. So this is what we get through to our patients. A higher activation of cardiomyocytes, it causes additional calcium buildup because during the diastole, calcium is not excreted from the cardiomyocyte. So the tachysystole is clearly identified. The progression causes the fibrotic changes, causes the progression of cardiomyopathy, causes progression of fibrosis. If we get the clinical results, then we will be able to stop the progression of fibrosis. The issue number two, nuance number two, building on the previous trials, we can say that, and what we do is IPV. We isolate pulmonary veins as the initial stage. And there is indeed a number of patients, or a significant proportion of patients, or a certain proportion of patients in whom this works out. If this patient comes back, we are not limited by the 3 months time frame in this case. We give more time for the scar to form. Again, for pathoanatomy, this replacement of bad porous tissue with proper elastic connective tissue takes from several months to a year. So if it's a redo procedure, we'll look at the existing isolation. Is it intact or are there any issues? The isolation is incomplete. We add additional lines. We do it in a high quality manner because additional lines which are not completed might be the substrate for further atrial flutter or atrial fibrillation worsening. Esteemed Yuri, what about you? Thank you, Aras, for your opinion. The redo procedure. I'm going to do it the same way as the first procedure. Let's imagine it's a good result, and well, anyway, it depends on the first methodology. If there was the paroxysmal form or isolation of pulmonary veins, we'll do it. Induction of arrhythmia, if we see flutter, it will all depend on the outcomes of this procedure. If there is a flutter, one type becomes a second type, so might shifts to the third. And the previous preliminary mapping shows that the myocardium is viable, so we will not go for ablation. On the other side, on the other hand, if we see a totally fibrotic lesion, well, this atrium is as bad as it gets. I mean, we cannot make it worse. When the viable myocardium is virtually not present with flutter, we will search for those residual potentials. We will try to boost them, because the contractility will not be worsened for the reason of lack thereof. There's none. There's almost none. In this case, yes, we will fight until the end. Thank you very much. Thank you. Thank you, Yuri. For the cardiologists present, those watching us online, those with us today, let me just say this. Before I go to you for questions, I would like to voice my standpoint. We have 3 surgeons and we have 3 non-surgeons, so people who don't do ablation during our conference. We will definitely, or in the redo or in the de novo procedure, we will not be adjusting the scope of intervention based on the fibrotic changes in the myocardium of the left atrium. Our experience helps us that. Hopefully, we're not, say, blind in this hope. So we've been following up these patients for quite a while. We're optimistic traditionally for both severe fibrotic changes in LA myocardium. There is a very simple justification to that. We understand that monitoring the cardiac signal, we only see the projection of fibrotic changes on the endocardium. We cannot be sure that they are transmural, that they go across all the thickness of the wall, of myocardium wall. That's obviously the case. Even the most modern, the most advanced tomographer scanner will not let us monitor. It cannot give us the fibrotic picture completely. It's beyond its resolution capacity. If it's a Napoleon cake, we see that kind of tissue, and the fibrotic changes are like the cream in this Napoleon cake, this layered cake. Then talking and making judgments about the trajectory of depolarization wave, or talking and making judgments about the pericardiac changes, we need to know exactly what's happening throughout the thickness of the pericardium of the myocardium. We don't have the technology. Likely it's going to emerge in 5 to 10 years time from now. In that case, we'll be able to talk specifically what do we see exactly when we're picturing the signal, or we see the fibrosis, or we see the fibrotic projection. So again, we will do the redo same as the first session, without any linkage to the fibrotic changes for the arc, for the posterior wall. That's our position. But to complete our experience exchange, the surgeons and non-surgeons, I would like to give the floor to our non-surgeons. Ladies first. Irina, you'll have the floor now. The opinion of these surgeons. You as a cardiologist, so what is done to patients for a redo procedure? Yes, indeed. I've had more clarity on that thanks to our meetings. I'm very interested in hearing what interventionists, what surgeons have to say, because their patients still are referred back to us to ask for our advice. And we talk interdisciplinary, we talk to each other. And I see that we will send more and more patients for redos. Thank you very much.
Ирина Вячеславовна. Ирина Вячеславовна, заканчивайте.
Irina, you can complete your question. No, it's fine. It's just after comments. I've given my main point. What I wanted to say, this loss of contractility in the atrium with preserved sinus rhythm. So there's a huge scorched earth fibrosis stuff. And, well, me as a cardiologist, I will care more for sinus rhythm. Me as a cardiologist. So this will be a higher benefit when managing these patients. Thank you, Sergey. A question to you, if I may. You've listened to the presentation. You can hear me. Okay. Can you please comment the same way? 3 various opinions of interventionist colleagues. 3 various opinions, 3 differing opinions about what they would have done for redos. Well, first of all, I would like to wish the surgeons to have fewer patients that require redo, because our patients are supposed to live longer and the lifespan is increasing. The substrate is building up, and the likelihood of redo is going to increase nonetheless, no matter how hard we try. I would like to see some part of the patients referred to pharmacotherapy, to be sent to cardiologists for drug therapy. And so patients should be selected quota-based for redo surgeries? Who is the right candidate for the procedure? So some of these patients simply cannot pay for it. So drug therapy is the only option for them. So we act according to the situation. We have antiarrhythmics on standby, but redos, like I've heard today yet again, they can change this situation for the better more radically. Yes, thank you very much, Sergey. And dear colleagues, can we go back to what we've been talking about before today? Quite obviously, we are talking about atrial fibrillation, sudden cardiac death. Viktor has outlined the position to benefit, or the position highlighting a very important fact that we all know full well, the prevention of cardiac death that we've seen developing for years now, for decades now. If we want to prevent sudden cardiac death, then the emphasis or the effort number one should be gearing towards non-drug-induced methods for cardiac death prevention, sudden cardiac death prevention. I will not be surprised that in 10 years from now, everybody will know clearly that it's not about what the key point is prevention of SCD, but we tend to forget some of the important points. Multiple times it was voiced. Viktor has said it just now. Class 1C of antiarrhythmic drugs for AF patients, say a patient that underwent RFA once already, there's a history of one intervention, definitely there's going to be fibrosis, definitely there's going to be structural changes in the atrial myocardium at the minimum. We live in the COVID era right now. You may have heard the German MRI gadolinium scan screening that mild, moderate, and severe cases of COVID pulmonary manifestations are aggravated by myocarditis. In this case, how do you think the structural remodeling of myocardium is going to happen in the main category, in the principal category of patients, in the largest proportion of patients? Yes, these patients are definitely not structurally intact in terms of heart. Their heart is not structurally intact. The class 1A was discredited in the CAS trial, but we should keep in mind that for us, Russian citizens, there's a number of domestically produced pharmaceuticals that was not included into the CAS trial. For this reason, the pharmacological potential, pharmacological capacity and evidence base is virtually non-existent with respect to their effect. Let me get back to the question that we've been discussing. Class 1C AEDs, structurally changed heart, a patient with AFib, with a history of surgery, with fibrotic changes, with obvious signs of atrial cardiomyopathy on MRI with gadolinium, or say for a redo RFA and direct 3D mapping of endocardially, this patient with minimal manifestations of heart failure, with no history of MI, and nonetheless, as we've just heard, it's a potential candidate for premature death, including sudden cardiac death scenario. So this patient, can they benefit, or should they be prescribed class 1C pharmaceuticals? Tell me please. Viktor, your take. I believe we've lost connection. Sergey, maybe you well, I will just go by my personal experience on that. Unfortunately, there's no RCTs, randomized clinical trials, especially involving our Russian domestic pharmaceuticals. Going on previous experience, my experience, plus the COVID era that we're living, that we're traversing right now. So I can share the experience of carefully selected patients treatment. Patients with preserved LVEF, no MI, none, no scar tissue. These are the patients. Patients with wall thickness under 14 millimeters, hypertension. So these patients are successfully treated at our clinic. I've not seen ventricular arrhythmia. I've not seen sudden cardiac death. So there is a niche for 1C drugs. It's not just young patients with cardiomyopathic forms of arrhythmia. It's more advanced pathologies as well, but well, without crossing some line, some red line, beyond which it will be impossible to use class 1C drugs. Thank you. Yuri. Yes, Irina, please. May I just throw in one brief remark? I do mind broad application of 1C class for ischemic heart disease patients, because a minor infarction is a very relative phenomenon. Ischemia, lack of ischemia, same thing. Our patient has no ischemia now, but efforts, say running after the bus or going up to the 5th floor, yes, I don't think that class 1C drugs are going to be safe for that patient. So it's indeed thoroughly, carefully selected patients. No hypertrophy, proper wall thickness, no infarctions, no history of infarctions, no inducible ischemia. Okay, that's your criteria. I thank you for those. I have a question to Yuri. Yuri, I can't keep being impressed by the prolific work of our Ukrainian colleagues, Professor Sychov, his colleagues. They were looking at etesizine use in patients with atrial fibrillation, their positive experience. We keep discussing that. What's your private experience in that? What's your personal experience in that? Because you're geographically closer to Professor Sychov. My personal experience goes back to the Soviet days, when there were ampules with etesizine back in the Soviet times. We were looking at acute forms. I was a young guy at the time. Honestly, I was quite optimistic. However, I'm not as optimistic for etesizine right now. The more severe the patient is, not just structurally, but the more senior patient it is, the higher count of comorbidities, COVID infection even, the less we need to prescribe this 1C class etesizine. Its efficiency is well within 50%. I'd go for beta blockers, which are well proven, or sotalol, or flecainide. Well, I think 1,000 times what I would like to get in exchange and what kind of hazards this patient is looking at. So this optimism of about class 1C is going down in my case. It's dying down. We've had problems with this pharmaceutical because it's manufactured in Latvia, as far as I remember. It's quite difficult to even get it, let alone prescribe it. Thank you. Thank you. Victor, your take, we know it. I thank you. I thank all the people who have taken the floor for this topic. If I may, dear colleagues, I will announce the concluding report of today, which logically stems out of the report of Viktor. It will be dedicated to novel technologies. Riccardo Cappato opened our conference today. His company initiated this implanted subcutaneous cardioverters defibrillators, completely subcutaneous, no electrodes inside this heart, just beneath the surface of the skin. There is a logical link between atrial fibrillation and sudden cardiac death. We should definitely look at novel ICDs, which is new for all our countries, especially given that it's clinically tested these days. These types are quite affordable. They're virtually available for free to our patients, at least most of them. So I'd like to give the floor to Anna Sviridova. She will deliver a presentation. Unfortunately, Alexei Knigin fell ill, so it's common cold, hopefully not COVID. His colleague will deliver a report on the prevention of SCDs using the implantable cardioverters defibrillators technology. Good afternoon, dear colleagues. Thank you for the opportunity to present my report. Where's my next slide button? Seems to be malfunctioning here.
Хорошо.
Right, back to normal. So, we're talking about prevention of SCD. How do we stop sudden cardiac death? Well, before it manifests, obviously. Epidemiology is clear. Incidence is here. Globally, 4.2 million cases per year. Up to one case per 1,000 population in Europe. In Russia, there's quite a lot of people. Well, different figures depending on the criteria you apply. 143,000 up to almost 500,000 of sudden cardiac death. So that's a huge burden. So of course we need to somehow try and address it. And the main SCD causes ventricular tachyarrhythmias, ventricular flutter, and VFib. That's the most frequent causes of ACD, 75 to 80% of cases. So no matter what kind of disease is underlying, there's only one answer: defibrillation. VFib can be targeted or can be treated with defibrillation. The faster we get to it, the higher success rate or higher hopes of success, at least, we will get for the patient. All the practicing cardiologists know that the sooner we start with defibrillators, the sooner we'll get the success and higher success rate. Given that most cases are happening at home, and there might be no one around that patient to give them help when they most need it, well, to avoid dying. The very second when that assistance is required. Of course, to remedy that, or to, well, a big gratitude to the engineers who developed ICDs and the doctors who implemented them into clinical practice. By the year of 2000, it was proved that ICDs are efficient for secondary prevention of SCD. If the patients survived SCD, then the secondary prevention is achieved with ICDs successfully. So why wait for the first episode? There was a consideration next. Are there any predictors or manifestations of the condition of the patients? Maybe we could implant them for primary prevention. Many clinical trials, of course, it's not new data, it's by no means new. If we implant ICDs, we will achieve primary prevention of sudden cardiac death. Over 30% mortality reduction for ICD implantation. Of course, it's not 100%. Unfortunately, we're not going to be able to save them all, but we will save quite a high proportion of patients because of the ICDs. As long as it was clear that the device exists and they help quite successfully, the implantations started growing, well, exponentially. It's a commonly accepted, widespread treatment method. Maybe high cost could be a constraining factor. Well, it's not that affordable to get it implanted into every patient that needs one. However, the number of implantations per million people, 101 ICDs. But the need is sixfold, 6 times that. I can say that out of the countries that are doing implantations, in Europe, it's Germany, the Netherlands, not even UK. Germany and the Netherlands, they are reaching this 600 devices per million population. They're getting to the threshold. If we recalculate Well, basically, the higher number of implanted cardioverter defibrillators is reducing mortality. Even you compare it to other developed countries like Poland or neighboring countries. So it's just me doing the statistical analysis. There were no specific trials looking at that. ICD therapy development caused less and less invasive devices to be produced and implanted. First of all, there were some external devices that were implanted into the abdominal cavity. Then they became transvenous, multifunctional. Then the technology reverted. We went to subcutaneous ICD, SICD. The devices became more and more sophisticated. Then the technology did a twist, and for the better. There was a number of important steps. Evolution of sizes is also manifested here. Quite small, smart devices. They are used for secondary and, most importantly, primary prevention of sudden cardiac death. Modern day ICD is a full-fledged cardiostimulator, pacemaker. It also treats bradyarrhythmias, tachyarrhythmias. Heart failure predictors can be diagnosed by contemporary smart devices. Remote monitoring by doctor. So online alerts to doctors sent about events registered in the patient's body. Some shocks. Predictors of worsening condition of the patient. So these devices are really smart and really comprehensive. I mean, these are computers which can be applied diagnostically in a very broad scope. So what they do is clear, everybody knows that. Anti-tachycardic stimulation and so on. For the device to be active, an electrode must be put. There could be a single coil or double coil electrodes, depending on the number of coils. Previously, bicoil, two coil used to dominate dual coil leads. It was believed that the dual coil will contribute to better prevention, but now the tendency is single coil leads. Why do we gravitate towards single coil leads? Well, we started saving more and more lives, young lives. People started living longer. The batteries don't last forever, so the devices had to be re-implanted. So the patients also survived even the leads. A bispiral, bicoil, dual coil lead is much tougher to replace than the single coil one. So more and more implantations, so more than one implantations for a single patient. Of course, a single coil were beneficial. Risks of complications, 15.5%. So the patients were supposed to benefit from the prevention of the sudden cardiac death, but at the same time, there was a risk of complications over 6 years of follow-up. So yes, we prevent sudden cardiac death, but we subject them to even higher number of complications than the risk of the sudden cardiac death he was facing in the first place, if we want to remove and reinstall this lead. So bispiral, or just a bicoil lead, this is the appearance post-extraction. Of course, it's a huge issue. Infections, quite frequent. Defects of leads. Previously implanted leads, the number of implantations is growing much faster than the development process. The problem is, how do we remove the stuff that we put in back then with a lower risk for the patient, with as low as possible risk? Complications in hospital, complications in hospital mortality, infected devices. So the engineering thought completed full cycle, and they realized, the engineers realized, that the device should be efficient and safe with respect to fewer complications. For this reason, subcutaneous ICD was created. It is implanted almost completely under the skin. All this transvenous device is also implanted subcutaneously, but the leads go into the heart. In this case, no leads into the heart. If we install this device for primary prevention, even in the future, a patient might need to switch for transvenous device. At least for some time, we preserve the patient's life quality against this. We prevent this early contact of the patient's heart with the lead. So in less than 2 decades, in the past 17 decades of the development of this subcutaneous technology, there's been 3 generations. In many countries, including those forerunners and frontrunners that I've mentioned, Germany, the Netherlands, less so UK, primary and secondary prevention of SCD is reached by implanted CDs. So the focus is shifted to subcutaneous defibrillators. We get full-fledged prevention of sudden cardiac death without the problems with leads and extraction of the leads that I've mentioned. From scratch to full-fledged implementation into the clinical practice, 17 years is a very small time frame. From a prototype to a method of choice, to device of choice, less than 2 decades. That goes to say a lot. In 2018, the first implants started in Russia. When I was preparing this presentation last week, there were 20 devices in these 2 years installed. Now it's 22. There is clinical approbation running that unfortunately took a hit from the COVID pandemic. We don't know what the second wave is going to look like, but still we hope that the clinics that were participating in the clinical approbation stage for ICDs, for SICDs, they will be able to complete that stage. So they're designed for this year and next year. So I hope that this small number will increase gradually. SICDs have some constraining factors. Unlike the transvenous one, it does not operate as a ready. It cannot stimulate. After the shock, it can also stimulate through the thorax, but it's painful. It cannot be continuous stimulation. If the patient requires stimulation, if the patient has some persistent tachycardias that can be treated with the cardiac stimulation, or if the CRT is indicated for a patient, we cannot install an SICD. In other cases, and the predominant predominant proportion, 80% plus, SICD can be considered a method of choice, a device of choice. Unfitting EKG or improper EKG. The device is located under the skin. So this is the body and this is the coil of the device. It reads, its readings are between these 2 points. And we're supposed to look at the EKG between these 2 points. The system then automatically looks at R and T peaks. The system then diagnoses whether it would be possible to avoid double counting when searching for arrhythmia. Repeated T wave. Will it be counted or not? So this is the only constraining factors, but that's quite early. Before then, before this time, we had to use actual rulers to try and navigate around the situation. Right now, there is automatic screening, automatic scanning available. So these are the components of the system. This ICD, this is what it looks like. It's a bit bigger than implantable cardioverter defibrillator because it comes well, I mean, its surface, the discharge energy depends on the surface area. So you cannot make them infinitely small, otherwise the energy potential will suffer. long-term observation of the patients with subcutaneous ICDs. For CE mark, this trial was run. A very low percentage of patients that had to be switched to transvenous, only 3 out of 55. The risk of complications, I've shown a 15% risk of transvenous to transvenous, replacing the old devices with new ones, 15% risk increase. In this case, only 3 out of 55 patients required replacement because they had some additional stimulation. No peri-op complications. There were some infections once, but they did not there was no generalized or system-wide infection. There were no issues with the lead malfunction. Since it is under the skin, it's more rigid, it's more sturdy, it's not as tender, it's as a transvenous one that obviously contacts the intima of the vessels, the actual tissues. So this sturdy catheters in SICDs is more robust. Effortless registry, almost 1,000 patients. Only 1% of patients required the replacement of the SICD because of the stimulation requirement. So this is the first objection. If you select the patients right, if you don't enroll or if you don't implant this SICD to already compromised patients, everything's going to be fine. The need for replacements will be much lower. The system is easily removed. There is no indwelling issues. So, I mean, it's very easy to replace it if this necessity arises. I mean, the patient can contribute or can get several years of lead-free heart, basically. Meta-analysis of 5 comparative trials. This is the comparison of subcutaneous and transvenous ICDs. Logically, the lead-related complications were much higher in TV ICDs. System failure and infection were roughly the same. But like I said, the system infection for a TV and the local infection for an SICD, well, that's different things in terms of complications and in terms of mortality risks. Oversensing and inappropriate shocks were roughly in the same range. I mean, this issue with ICD therapy, well, the shocks when they were not used, were not needed, inappropriate shocks. However, SICDs and TV ICDs were not different in this. Supraventricular tachycardias are better treated with TV ICDs, but those are not really requiring treated. T-wave oversensing was much more frequently seen in SICDs. But since this analysis included some trials with the first generation of SICDs, they simply lacked the algorithms that the contemporary devices already support. Since this was a rapid development process, the engineers started learning on their mistakes quite quickly, and the new algorithms were introduced into the new gen of devices to eliminate this dual counting of the T-wave oversensing. There's much fewer inappropriate shocks these days in contemporary devices. In 2020, the Praetorian trial was run. Not some small time. It's a multi-center, randomized, non-inferiority trial. 849 patients that were split into 2 equal groups. Patients that did not have indications for stimulation, not one arm, neither arm. They were randomized into 2 groups, SICD and TV ICD. Complications-wise, inappropriate shocks-wise, no significant difference. So this Praetorian trial was supposed to prove that a subcutaneous ICD is non-inferior than transvenous one in terms of prevention of sudden cardiac death. The trial has indeed confirmed that. The further questions, well, basically there are the questions about the cases where subcutaneous ICD can be superior to transvenous ICD, but at least this trial has shown that there is a non-inferiority point. These are the further primary composite endpoint. further slides of this trial. Various complications, dangerous complications, infectious stuff, inappropriate shocks, lead-related complications were all summarized into this primary composite endpoint. And you see the curves are virtually the same. This is the separate device-related calculations and inappropriate shocks, subslides B and C. Now, there was an insignificant difference, lower count of device-related complications in subcutaneous ICDs, a bit higher count with inappropriate shocks with subcutaneous ICDs, but in both cases, this was not statistically significant. There was no statistical significance between the two. These devices are roughly comparable. This is the conclusion of the Praetorian trial. Again, it's this year's trial. I wouldn't say it's a breakthrough trial. It only builds the foundation or paves the way to doing this treatment for patients that require prevention of SCD. So it was supposed to show that SICDs can become the part of the paradigm. It's not some novel methodology that requires some additional proof. So this was not a breakthrough study, but it was supposed to prove the concept. Untouched trial, a smaller trial, was also recently completed. SICDs were implanted for patients. There was no comparison to transvenous ones. It's just SICDs. Number of inappropriate shocks, only 2.4%. This is the first trial of 2013, IDE, dating back to 7 years ago. 13% of inappropriate shocks. So you can see the development of technology over the span of a mere 7 years. The technology progressed. The new algorithms of T-wave sensing improvement has reprogramming, firmware, implantation of it's not just engineering. I mean, there was also some medical progress that contributed to the reduction of these inadequate shocks by 5 times. And possibly there's also a hope for further reduction of inappropriate shocks, going not to zero, but this problem will become even less significant, much less significant than it used to be back in the day. Russia is running clinical approbation, like I've mentioned. In 2019, the protocol was approved. Unfortunately, because of the tough epidemiological situation, this trial is not progressing as fast as possible. This clinical approbation. 22 have been implanted within the framework of this. These are the clinics that are participating in this clinical approbation initiative. I hope that this device passes successfully the clinical approbation stage and it becomes available to the broader clinical practice. Hopefully, the patients will have the opportunity to get this device free of charge through insurance or through some targeted medical assistance or medical aid. So they will have the opportunity to prevent sudden cardiac death without increased risk of complications. Thank you very much for your attention. This completes my presentation.
Спасибо большое, Анна Александровна.
Thank you very much, Anna. Esteemed colleagues, I would like to cordially thank once again all the participants of our today's webinar. Let me remind you that all these events have been run on the eve of the opening of our portal. Unfortunately, Viktor left us, disconnected. He's the acting president. He's the current president of the Eurasian Association. His initiative, his goodwill has helped us all progress. It has joined all of us around him. So right now, we are moving to an important stage of the promotion of our association. Russian language portal will be inaugurated, will be unveiled soon, dedicated to arrhythmias and the issues, related issues. Hopefully, the journal of the association will be registered successfully quite soon. Next September, there's going to be yet another Congress of the Eurasian Association. These events, as you can see, is not just a friendly exchange of experience. Of course, we definitely take joy in seeing each other. We are happy about the colleagues joining us online and promoting this knowledge, promoting this humble effort of ours further, passing the word. The first webinar was quite broadly was quite successful, many thousands of views. The second webinar was also interesting to our colleagues. This is our third webinar of the series. Here's hoping it's not the last one. I hope that the next events will be running on the platform or the portal of the Russian, of the Eurasian Association. Hopefully, again, it will be unveiled soon. So, your final remarks. Everyone is welcome to take the floor. Dear colleagues, whoever's still with us, please, let's complete our today's meeting with a round of experience exchange. Aras, you have the floor. Thank you, Aras. Well, I think that the last people standing, last of the Mohicans, have stayed on. Yes, still it's an indicator. It shows that it's been an interesting event. I must confess that over time the habits stay on. As a student on the last night before the exam, it's this preparation for the exam is the most productive one. So I thought that today I was supposed to change that slide, and I thought maybe I should improve this slide. Well, still, there's a room for improvement. In my case, all the reports have been very interesting. The webinar has been interesting indeed. Those who will be watching it will indeed benefit. If everything we do is going to benefit our patients, with AFib patients, that is going to be our small yet important contribution. So thank you very much, Andrey, for the invitation. Thank you for this cohesion effort, the Eurasian Association that brought these experts, the area experts together. Thank you. It's really been a pleasure. Thank you, Aras. Anna, you have the floor now. The concluding remark. Well, my report was less about atrial fibrillation. It was more about defibrillation. But still, I believe that SCD, or prevention of sudden cardiac death, is very important. VFib is not AFib, but it's even more dangerous. It's always a pleasure to have the floor at your meetings. This pandemic format moved us online, but still, it's still very heartful, very cordial. It brings together the experts that might otherwise be even unable to make it there physically. But the webinar has given them this opportunity. So we're expanding the scope, we're erasing the borders, more information for more people. Anna, by the way, this limited domestic experience, SICD implantation in patients with atrial fibrillation, is there a cohort of patients like that? Yes, there is. Of course, it's a small one. And I don't see any obstacles, any constraints to the implantation of ICDs in these patients. Contemporary devices have not had any problems. Differential diagnostics for higher heart rates, higher frequencies have been improved. Plus, the new ICDs has an AF monitor. I mean, patients with a documented atrial fibrillation will benefit from the analytical and recording of some episodes of this atrial fibrillation for the following consideration by the doctor. So, of course, the follow-up times are quite small, but just again, I wanted to highlight the diagnostic features of this contemporary device. Well, that's it. Okay, could you please tell us, within the framework of the clinical approbation, these centers that are participating in approbation, is there a database where the data is streamed and logged in for long-term tracking of this therapy? I mean, within this approbation effort, we've been talking about combined management using the combination of various therapeutic or pharmaceutical and intervention approaches. Are we going to be able to look into the nature of medical assistance history? No, there's no common registry, unfortunately, to the best of my knowledge. The clinical approbation is handled by the Russian center, the cardiological center is the head center in the approbation trial. But they will generalize the information and they will summarize it. But it's only going to happen in 2 years. Unfortunately, we'll not be able to monitor those patients across the board. Every clinic will will monitor their own patients. Yes, it's a big drawback. There's no generalized registry, but it was not envisaged for the clinical approbation stage. Right. Just have in mind, should you have the opportunity, talk about that. There's a great internet platform that EURA sports for long-term monitoring of patients, even open heart surgeries, other. So this platform is called Dilemma. It's easily transformed like a Lego, bunch of building blocks. It can be transformed into a wonderful database. So we are completely open to cooperation. Of course, I believe that if this technology continues to develop, I mean, if the clinical approbation is okay, we'll be able to create a registry for patients beyond the protocol of clinical approbation. So patients that are going to benefit from the implantation of the device later on. So some people are quite jealous about their results. So there will be no intellectual property in the same way, in the same manner that it applies to clinical approbation. When clinicians want to test their own results, want to see their own results, and not give it to anybody else. But other than that, a Russian registry for transvenous and subcutaneous ICDs, it will be very important. The Danish registry exists. The Dutch also have a huge registry for subcutaneous defibrillators. So it would be nice to have one in Russia, of course. Especially all the resources are already available with long-standing track records for formative years, teething problems, deployment, testing. We can definitely do that. Esteemed colleagues, we would like to thank everyone who has taken part in our today's event. We welcome everyone who is going to watch it in the recording. This, from my opinion, it's important, critically important material. And here's hoping that we're going to see each other time and time again within the Eurasian Association activities, be that online or reading each other's articles, or this second edition of the clinical arrhythmology. It has just been prepared. It's the first Russian manual on arrhythmias, which is ready to be published. Second edition, expanded, revised, improved.